So good afternoon, everybody, and welcome to this grand round in which we are going to focus predominantly in terms of technological advances with regards to pediatric endocrinology. And we know pediatric endocrinology is one branch which has witnessed a lot of changes. And often when we talk about technology, we traditionally have been talking about how new devices have come up, or whether you have got a new way of giving glucose monitoring, or you're doing some new insulin. But what we're talking about technology today is to how these protocols are properly implemented at the last point. And this is what the aim is, to develop point of care tools which can help out in terms of improving technology. So our aim has been to develop tools which can be implemented in different regions, across resource settings, across the different exposure in that regard. And we'll be focusing about how these point of care tools can help guide 5 key disorders in the form of growth, puberty, thyroid, glucose, and electrolyte disorders, and how we can individually look at in terms of evaluation, assessment, and management of these disorders. So this is going to be a longish sort of a program, but it's a compressed version of our larger program of practical pediatric endocrine course. We want to be more practical in terms of providing a direct tool which will help out reach this scenario. So iPedendo basically is a way in which we want to go out in terms of developing tools which will help in terms of evaluation of these key disorders using a very novel approach of mobile application, which has been there now for some time, but we have been keep on editing them in terms of improvement. So our work with regards to pediatric endocrinology actually started maybe around 13-14 years ago, when we started with workshops on different disorders. This was much early. Then we gradually developed those workshops into 6 modules, which were in the form of a practical pediatric endocrine course, which we conducted across the country. Then we realized it's going to be difficult to keep on conducting programs in that extent. So we went on to social media in terms of YouTube, in which large number of videos were available. We started an on-site fellowship around 6 years ago, and till date we have got 11 fellows who have joined who have done or are doing the clinical fellowship in that regards. Then we realized that we also need to spread out the message, and that led to the development of Medi classes around 5 years ago, which is a portal dedicated towards improvement in pediatric endocrinology, which then further led to the publication of multiple books, and then the mobile application. And we are going forward in terms of these regards, and we'll talk about the subsequent developments which are happening in that regards. One of our important interventions is the e-learning tool, which is in the form of a YouTube channel, which has got extensive resources. Pretty much everything about pediatric endocrinology is there, and it's quite widely viewed across the globe as well. We have got our website, learning.growsociety.in, which provides validated courses with regards to various aspects of pediatric endocrinology, and they range from small courses like growth, puberty, to more specific and larger courses in the form of the fellowship programs, as well as the pediatric endocrinology for postgraduates and other programs in the form of, which are available on an online or an online on-site hybrid model. We have got 3 key books which focus from practical approach to basic to advanced pediatric endocrinology, which provide a comprehensive understanding of these tools. But what we realize essentially is that with all the knowledge and resource, ultimately, when you are seeing the patient for the first time, you may get puzzled in terms of how to implement all the knowledge, and therein the confidence becomes a bit difficult. And whatever you remember will not always be a sort of a standard of care, and often that results in errors. So there is a need in which we really combine between the knowledge which is there in terms of available, in terms of resources, in terms of guidelines, in terms of algorithms, with what we really practice in that regard. So how do we do that? There are multiple factors required. You need to decide about which tests to order. You need to look at the interpretation of each and every clinical sign, as well as the investigations. You have to then decide about what treatment is there, and that's why you need to have a very comprehensive approach on that. So we tried to develop a solution which can help out in all of these things in terms of analyzing the symptoms, interpreting the key parameters, advising investigations, then comprehensively looking out on investigations and deciding about that treatment. And we realized that the most powerful device there would be a mobile application, because if you think of it, mobile app is available to everybody, and all of us keep carrying that mobile everywhere. If you talk about, let's say, a web portal based approach, it requires at least an office setting. So this can be used across settings, very easy to do, and you just develop and can be used across the globe as well, providing same standard of care at different regions in that perspective. So this led to the development of our mobile application, which was developed a few years ago, which is in fact the most downloaded endocrinology app all across the globe, with number of installs and a lot of publication that we have done in that regards. The way we structured this is to develop pathways which provide us guideline-based approach in an algorithmic manner. You have to question and answer, and you will get the final diagnosis in that regards. There are approach pathways and management pathways. So they will guide stepwise management and approach. Suppose you want to know about hyperkalemia, it will ask about specific conditions, and then we'll go in terms of diagnosis. More recently, we move more towards interpreters, which are instantaneous, because now the general tendency, you don't want to go and wait for a long time. So you just put in some data, like in the form of a thyroid interpreter, you interpret the thyroid results and you get the results automatically. Similarly, the bone age interpreter, which has been published and validated, which provides a wide, and we'll discuss about this tool as well as more disease-oriented interpreters, in which based upon your symptoms, we will then decide about what workup is required and how do you reach a particular diagnosis. So we've got multiple interpreters like puberty interpreter, obesity interpreter, DSD interpreter, which really guides, and we are working on a combined electrolyte, calcium, and glucose interpreter, which is going to help out in that perspective. Now, once you order a test, you need to really understand the intricacies of when to do, how to interpret, and age-related. So, of course, we don't have all the information, and that's why we have put it every detail in the diagnostic section and information about every drug in the therapeutic section. So within the app, you can actually, once the patient comes to you, decide about what investigations you want to do. You can then decide about how to send and all the information is there. Once the results get in, you can interpret those results, then you can prescribe and you can know about the particular drugs as well. So we sincerely hope that this endocrinology application is the bridge between the evidence base and the practice. So this is expected to result in evidence-based practice, and we already have publications which have shown its improvement in care in terms of decay, growth, and bone age assessment. And we are working in terms of validation for many more disorders like diabetes, DSD, puberty, obesity, thyroid, and it will help out in terms of that. So what we'll do out here is that we'll try to go through these various disorders, and this is mainly about practical approach to particular conditions and how these technology can help you out reach that. So we'll focus about the key areas: growth, which includes growth and obesity. We'll then move forward about glucose disorders, which includes largely diabetic ketoacidosis, as well as a bit about hypoglycemia. Pubertal disorders, which also includes approach towards DSD. Thyroid disorders, predominantly congenital and acquired hypothyroidism, which a word a bit about thyrotoxicosis. And finally, hypo and hypernatremia. So it's going to be an extensive program. So we'll start off with how do we proceed. So we'll talk about growth, glucose, puberty, thyroid, and sodium. So let's start with growth. Now, this is a most common presentation which will be there in a pediatric practice. You have a 12-year-old girl whose height is 132 centimeters, weight is 20 kgs. Now, the quick question is whether this child requires evaluation or not. The most common presentation to a pediatrician. So as I said, 2.5% of all children will be short, but most of them will be physiological. And this is true for most endocrine conditions, whether you talk about growth, whether you talk about obesity, puberty, most of them represent a physiological variation. And maybe 10% will have a significant pathology. So what you want to do is to not unnecessarily work up these 80% physiological cases, while you don't want to miss these 10% who can have a life-changing disease like celiac disease or a life-threatening disease like craniopharyngioma. So this is the work there. So now if I talk about growth failure, this is from our review paper in IJP, which talks about the various forms of growth failure. Essentially, when you talk about growth failure, as I said, 80% is physiological, which is characterized by a child who is, even if he's short for the population, is not short for the bone age and not short for the family. And I think this is the three things to remember. If you are saying a child has a pathological failure, he would be short for the population, short for the bone age, and short for the family. So if he falls in any other, it becomes physiological. Then 20%, 10 to 20% may have pathological forms. Then you may have a problem either at the level of the growth plate or at the level of environment. So when I talk about primary problem in the form of growth plate, cellular scenarios, you may have a SGA who may have a symmetrical SGA who is not catching up. You may have a syndromic cause which is there in the form of various syndromes like Turner syndrome, Russell-Silver syndrome, and Shock's defect. Then you can have skeletal dysplasia and rickets, so intrinsic problems. Then secondary problem, which are the most common causes in pathological causes, will either be a nutritional or an endocrine cause. So this is the key thing to remember. Nutritional will basically mean all the malnutrition, malabsorption, infections, while endocrine will be the hypothyroidism, growth hormone deficiency in that regards. So when we have a child with growth failure, the first question, of course, is it really short stature? Then if it is short stature, is it pathological or physiological? It's primary or secondary. So we'll now start off with our publications, which clearly shows that how do you define growth failure? So Vibha, can you tell me how do you define growth failure?
So if we go by this,
You can start. Now, in terms of general definition of growth failure.
so in the general definition of growth failure, like if the child is if we talk about the community, if the child is short for his peers, for his classmates, then definitely this will be an objective, subjective parameter.
Generally, we have been comparing it just with the normal population. But then it means that everybody who is below 2.5 centile will be short.
Yes, sir.
If the whole population becomes tall, everybody is above 6 feet, those 2.5% will always remain short.
Sure.
So what we try to look at it is what makes more sense in terms of the criteria. So whenever you talk about diabetes criteria, how is the diabetes criteria of sugar of fasting 126? Let's say.
So if the sugar of is more than 126 and if this
so why do you use 126 and not 116 or 136?
So because most of the patient with that sugar level of more than 126, their HbA1c is really high. They'll have symptoms of.
You have to look at complications. So what are you worried about? Long-term complications. So studies will say, okay, a level more than 126, your complication increase. A level above 100, slight increase. So then you will say this is pre-diabetes and this is diabetes. So same what we did was to look at what is the prevalence of pathological short stature with regards to severity of height. So if you look at somebody whose height standard deviation score is more than -2, the risk will be very, very low. But when you go to around -2 to -3, it becomes 40%, and less than -3, it becomes 80%. So 80% children who come to you with a height SGS below -3 have a pathological cause, which means that they need definitely evaluation. So if you now look at it, we have a traffic light approach of more than -2 SGS, you can wait, -2 to -3, you can have wait and watch, and less than -3, you need to work up from that regards. So how do you define this? You can carry from here in terms of the growth chart and everything.
So if we look into the growth chart, if the child, if we plot the height of a child and it is falling very below the 4th percentile, then this child really needs workup. We cannot miss this child. And if a child is not growing at all, and the height growth velocity of less than 25 centile is height standard, it's between the 1 and 3rd percentile, then this child also require workup. And if we look into another scenario where the child is not growing at all, it means the child, the height of the child is passing more than 2 centiles, significant centers. That in these 3 scenarios, the worker has to be done, and this is the definite case of short stature when we have these kind of child and we plot these child.
Of these 3, who will you be the most concerned about?
So the child not growing at all.
So somebody who's not growing at all would mean that they have a acquired cause. They may have a brain tumor for all you know.
Yes,
so you will be more worried about that. So these are the conditions you will require evaluation.
So if we go by the algorithm, definitely sir has told us the first question is whether to evaluate the child really requires evaluation in terms of investigation or workup. So yes, first step is to identify whether the child is short or not, whether it is pathological or physiological, because definitely in physiological, we need not to require do lots of workup. And so coming to the physiology versus pathology, because differentiating these two entities is really important and difficult also. So for this, we use the basic one, that is the growth chart. It is very helpful in the differentiation, along with the assessment of pubertal status and with the bone age assessment. As most of the pediatricians are not very well trained in the growth chart interpretation, assessment of the puberty, and also the bone age assessment. So it becomes really difficult for them to differentiate between the physiological versus the pathological. So these these following basic identification in these growth chart and pivotal status and bone age, we can really do wonders. So if we look into the growth chart, the first step is to see the absolute status of the child. That is where the child lies in the growth chart. It could be measured in the percentile as well as in the height SDS. Now, second step is to measure what is the children's height in comparison to his or her parents. And for this, we require the target height. And how do we calculate the target height? It is we add the father's height with the mother's height and divide it by 2. And in case of boys, we add 6.5 and subtract 6.5 in case of girls. But the target height SDS is also very important because we have to see what is the status of the parents with the reference population. And there is one important parameter that is known as the corrected height SDS, because it will definitely differentiate whether the child has the familial cause of short stature or the non-familial one. So for the assessment of corrected height SDS, we have to subtract the target height SDS from the height SDS. And if it is greater than minus 1.5, then this is the familial pattern of short stature, and we need not to do any investigation. We can follow it up. And if the corrected height SDS is less than minus 1.5, then definitely we need to follow this child for a log, and some investigations will be required. Now, coming to the differentiation between whether the growth pattern is nutritional or endocrine. Here, the importance of height and weight age comes. And as we all know, if the height is very much affected than the weight age, then this will go in the favor of endocrine pattern. But if weight is more affected than height, then it will be nutritional pattern. But we require an objective parameter so that we can easily differentiate between the nutritional and the endocrine pattern. And from our own study, we have evaluated that BMI SDS is very important parameters. On the basis of it, we can really differentiate it.
So there are two schools of thought. One, people who talk about the percentile values and the growth chart. So they will talk about what is the percentile, what is the target height from the chart, and height and weightage. And the other one, which will be talking more in terms of what is the height standard deviation score, corrected height standard deviation score, and BMI SDS. So what we need to understand that this is the same thing which is depicted in a different fashion. Which one of this will give you a more objective parameter, SDS or a percentile?
Sir, SDS, I would say.
So I would say that we need to, as a pediatrician, move from this percentile based approach to a more SDS based approach. Why? Because if you say less than first centile, it could be 0.001 centile or just 0.99 centile. But if you measure SDS, you will know that this is minus 2, 2.2, 2.4. You can be more continuous variable will be there in that regards. Number two, if you are following up, somebody is less than third centile and he remains less than third centile, what does it mean? So better to go ahead in terms of height SDS. So remember these three parameters when we talk about our algorithms: height SDS, corrected height SDS, height standard deviation score for bone age. This is another parameter which will come up. These three will really tell you whether the child is really short. If he is he short for the family? If he is not short for the family, then whether he is short for the bone age or not, and this will give you a clue. And BMI SDS is much better than the height age, weight age perspective in that regard.
So keeping in mind all these parameters, the height SDS, the target height SDS, and the BMI SDS, as most of the growth calculators do not provide the corrected height SDS and the height SDS for bone age. So, and we have made it possible in our growth interpreter, where you have to put all the data regarding the age, height, weight, and it will give the likely interpretation in the form of BMI SDS, weight SDS, and height SDS. So coming to the pubertal progression in girls, and it is very important to know when there is an onset of puberty. And for it, the stage B2 plays a very important role, because from here there is an onset of puberty. And from this stage of B2, there is a growth spurt of 20 centimeters from here to the final adult height. But we must keep in mind that it should be differentiated from the lipomestia, and we could easily differentiate by approximating the index and the thumb finger. And if there is a resistance between the thumb and the index finger, then definitely there is a breast node present, and if not, then it is a lipomestia. Now, the breast stage 4, the height from the breast stage 4, generally child gets about 10 centimeter from this stage, and from the menarche, the child is able to attain at least 5 to 8 centimeter. And in case of boys, the main thing that we keep in mind is the testicular volume for the pubertal progression. At the testicular volume of 4 ml, there is an onset of puberty, and at the volume of 10 ml, there is a growth spurt.
So I think the other thing to remember is that for most people, pediatricians do not want to really look at puberty, or it becomes very difficult to them to really assess puberty. So what we suggest is that just look at breast. You may have palpation only if you have a doubt between B2, whether it's there or not. Otherwise, looking at breast, look at B2 and B4. These are the two parameters which become very important. And for boys, testicular volume of 4 and 10 ml. So I've been talking about short for the family, short for the bone age. There is also a concept of short for puberty or not. So if you have a height of 130 centimeters and breast stage 2, you are expected to grow another 20 centimeters. You will be like 150. But you are 130 at a breast stage 4, you only will grow 10 centimeters. You will be 140 centimeters. You have got 130 centimeters at menarche, you will go 135 centimeters. You have got 130 centimeters with vaginal discharge, maybe 7-8 centimeters. So you need to keep your minds open. Similarly, in boys, if you have TV of 4 ml, you expect 20 centimeters to 25 centimeters growth. TV of 10 ml means the spike is going to happen now, maybe 15 centimeters or something. TV of 15, you start getting worried. So this pubertal assessment should always be commensurate with height. We have developed the interpreter which really helps you pictorially identify that. And in certain scenarios where sometimes it's culturally difficult to really get the pubertal assessment in a busy practice, you may actually ask the attendants or the child themselves to rate, especially for the female patients. We have found it to be reasonably good. In boys, of course, testicular volume has to be assessed very importantly. So this could be a surrogate marker in that regard.
So after the pubertal assessment, the next very important step is the assessment of the bone age. As we all know that maturation starts from the proximal to the distal, and the fusion of the bones start from the distal to the proximal. And in the very early age, like in the infancy, the number of carpal bones could be used to assess the bone age, but later on, the short bones and the long bones are important to assess the bone age. And girls are generally advanced by 1 to 2 years because of the aspect of the estrogen. And what we look into these short bones, actually we measure the size of the epiphysis with the metaphysis. And if the epiphysis is shorter than metaphysis, if it is equal, or if its scapping starts, then we can decide at what age the child is. And this is a very important picture which shows that the carpal bone and the number could be used in infancy and the toddler. And what I am talking about, the epiphysis site, when the epiphysis is smaller than the metaphysis, then it will be around 2 to 7. And if it is equal, the bone increases. And it is important to look when does the capping start, because from there the child would be around 10 to 12 years. And later in the puberty, we have to look for the fusion of the long bones as well.
So bone age has been one tool which has often been neglected in terms of practice because people have not been trained that much. And if at all, people just count how many carpal bones are there. What I'm trying to say is that take your focus off from the carpal bone to these distal phalanges. These are the most important ones. And if you have to look at one, it will be the middle phalanx of the middle finger. And then you just compare what is the epiphysis and metaphysis. And if you look at the ages, it's 2 to 13. This is the time when you want to do bone age. You don't want to do bone age less than 2 years. You don't want to do bone age beyond 16 years. That becomes very easy. So the most important thing, and studies have shown single side, you want to look at it, middle phalanx of the middle finger. You will get a good information. But of course, you want a more objective assessment. There will be other tools which are available. So which are the other tools which are available, Vibha?
So other than this extra, we have a GP atlas where the X-ray of the patient is compared with the specific age atlas that is provided in the GP atlas. It has very intra-observer and inter-observer variations. The next we have Tanner Whitehouse 3, where the 13 sites have been selected. And according to the maturation, individual score is provided to every site. Then the score is converted to bone age, and calculatively the bone age of whole hand is assessed. But this is very time consuming, around 10 to 15 minutes generally is required for the assessment. And the next we have is the bone expert. It is fast, it gives an quite accurate image, but the most disadvantage is it is very costly. So we have developed and validated a novel application for the bone age assessments. As sir has told us that the major 5 sites have been selected in our study, and they have shown that if we do the bone age by selecting these 5 sites, it will give a much accurate results compared to the Tenet White House bone age expert as well. So what we have done and how do we calculate the bone age assessment in our application? First, we have to select the middle phalanx of the middle finger. Then we compare this image with the images provided in the app. Like we select middle phalanx of the middle finger. Then we select the proximal phalanx of the middle finger. We compare the ulnar, the radius, and the proximal phalanx of the thumb. Then after selecting all the sites, the app will immediately gives us the bone age, which is very fast and very accurate. So after assessing the bone age, the pubertal status, and the growth chart, the next step is to what test should be done and in what order. So growth chart, puberty, and bone age is required in all the cases. Then they should not and they must not be missed in any cases. So, and for the differentiation of pathological short stature, for primary one, we should and we must look into the syndromic facies, the proportion of the body proportions, and in the SGA, we must make a habit to ask the birth weight of each and every child, those who come to our clinic. For this Turner syndrome, the SOC deficiency, karyotype is must in all the girls. And for the skeletal dysplasia, detailed skeletal survey is required. And in the nutritional causes, we need to do liver function tests, creatinine, TTGs to rule out any systemic diseases, blood gas, and calprotectin for the IBD. Coming to the endocrine causes, we need to do the free T4 TSH, the thyroid profile, the GH stimulation test, but they are done after ruling out each and every causes. So if I conclude, CBC, ALT, creatinine, TTG, FT4 and TSH has to be done all the patients who presented to our OPD with short stature, and karyotype is required in I will say karyotype should be done all the girls with short stature. Blood gas should be done below the 3 years of age and calprotectin above the 10 years of age. And in case when all these investigations come normal, then only we should proceed for very specific tests like growth hormone stimulation test and other sort of test.
So if we go by the approach now, if we use our more objective criteria, so we say look at height SDS, first the child is short or not. If height SDS is above -2, then don't worry at all. This child is not really short, no workup required. If height SDS is -2 to -3, then look at the family, whether the child is short for the family. Look at the corrected height SDS. If the corrected height SDS is within the 1.5 range, so 1.5 SDS plus minus of the family, that's normal, this is familiar. If, however, it's less than -1.5, then you look at whether the child is short for the bone age or not, and you look at using a height standard deviation for bone age. If it's less than -2, then you worry. If it's more than -2, then it's nothing. So 80 to 90% of cases will come out here. They will have a height SDS more than -2, a corrected height SDS more than -1.5, or a height SDS for BA more than -2. And in all these parameters, you do not require any evaluation. You just follow up, look at puberty, and go from there in that regards. However, if child is short for the family, short for the population, short for the bone age, do the screening, which already Vibha has talked about. We do recommend TTG in everybody, even if you have a nutritional or endocrine pattern. Blood gas only before 3 years of age. If these tests are normal, you can follow them up. However, if you have a child who is very short, who is below -3, then don't wait much. You can follow up and work up. Look for syndromic features. And then if they are not there, go for two things, IgA and karyotype. So we do not recommend IgA right at diagnosis because the yield of IgA is not too much. And karyotype also not in somebody who has got all the features of Turner's, but anybody whose workup is normal, you should do a karyotype at that point of time. Once that's normal, you go for growth hormone stimulation. IGF-1 and other workup, but that's the last investigation to be done in that perspective. So the key parameters are, again, as we started, look at the growth chart, bone age, parental height, and you will get the idea along with that in most of these cases. So based upon this algorithm, we have developed our tool, which was found to have a high level of concordance with regards to clinical diagnosis to the tune of around 99%. All you have to do is to put the data, what is the current height, what is the current weight, parental height, and you will get an output along with likely diagnosis in that perspective. And from here, we have tried to build it up further with the development of BIG, which is bone age assisted interpretation of growth. So Vibha, maybe quickly tell us about this.
Yes, sir. So this is slide. Okay. So BIG, it is definitely it is not available in mobile. It is a web portal and it is very simple to use. What you have to do, you have to input all the key anthropometric parameters, then select the pubertal status according to the images given in the portal, then select the specific sites for the bone age assessment, and you can do either by the manual entry or by the selection specific sites. Then based on the BIG provide an instantaneous pictorial growth chart, which includes the bone age, the mid-parental height, and along with the detailed interpretation of various growth parameters, including the target height SDS, corrected height SDS, and the height SDS for bone age, which is very important for classification of different growth disorders, along with the bone age report. And it also provides the specific interpretation with guidance, and it on the follow-up, it also provides the tracking form.
So we have tried to club all our algorithms into one, and this will just give you an instantaneous interpretation of growth, puberty, obesity, all the parameters. So let's start with cases. You have a 12-year-old girl, height is 132, weight is 20, father is 163, mother is 150. Do you think this child is short, Vibha?
So if we see the child's present status and on the growth chart, definitely the child is below the 3rd percentile. So definitely the child is short for his population, for other children's. But
you would like to have a look at the parental. So
definitely,
this is the parental height. And we have used these graphs, which will give you the upper and the lower limit. So typically, we talk about 1.5 standard deviation. So plus 1.5 minus 1.5. So now do you think this child is short?
So on the comparison with the parent height, this child is coming within the this height range of the parents. So definitely the child is not short for his parents, but we have to look for the height age and the weight age as well.
So what is really the height age and weight age? It's basically the age at which the current height and weight becomes the 50th percentile. So you draw basically by joining the 50th percentile and joining a perpendicular. So what's the height age, weight age here?
So height age and both is 9 AM, both are lower than the chronological 8. And here the role of our growth interpreter comes when we give all the inputs to the growth interpreter, then it will give the instantaneous interpretation about the BMI SDS, and we look.
So if you look at it, we have given the interpreter and it gives us this report. So what if we go with one of these parameters, it's basically saying that height is below -2 standard deviation score, but the target height SDS is -1.37, which means that she is not short for the family. So this becomes a familiar. You don't need to do any workup from here. But the important thing to remember is that often we forget about weight. Yes. So you see the BMI is -3. That's why this underweight has come up. So if you use this simple tool, you will not miss these pathologies very clearly. So I think that's important.
Yes, sir.
So this is familiar short stature. Second case is 12-year-old, height is 120, weight is 15. Now what we are seeing here is that workup showed TSH, TTG were normal and growth hormone level basal was low. IGF-1 level was also on the lower side, diagnosed as growth hormone deficiency. So do you agree with this diagnosis?
Definitely not, sir. First of all, we cannot rely on the single basal hormones level. We need to plot the patient's height on the growth chart.
If you look at the chart here, what you are seeing basically is here is that what seems to be more affected? It seems to be the weight which is much more affected. And if we go to the individual result, what you are seeing here is that height SDS is -3.85. So height is much affected, but the weight SDS is -4.88. So what does it mean?
It means the BMI SDS is less than -2, which is going in the favor of nutritional.
So BMI is -3.7, which means nutritional pattern growth failure. So does this fit now into growth hormone deficiency?
No, sir.
So it basically means that we are not having the right diagnosis. So we got the IGA done, which was undetectable. So always interpret the growth chart as per the correct reading and then order the investigation. Otherwise, you would be confused. Next case is a 10-year-old boy who is short, weight is 18 kg, parents are short also, bone age is delayed. Now this child, the workup showed a TTG of 32, and based upon that, they had diagnosed that this is mostly celiac disease, advised gluten-free diet, but there was no effect. So do you agree with the diagnosis of celiac disease in this case?
So, first of all, we have to see whether the which height age is affected or weight is more affected, and the growth interpreter definitely can help us in this.
If you look at the growth interpreter,
the height, we can see that the height is more affected than the weight. Right?
And if you look at these objective parameters, what do you find? You can interpret it for me.
So we can see the height SDS is very low. It is minus 5.68 standard deviation, and
so weight is short for the population. Then
and the weight SDS is minus 2.7, which is also in the lower side, but what we are seeing that BMI SDS is 0.6, which is greater than 1, minus 1. That is, it is not going in the nutritional.
Short and plump. So if you have a short and lean, that becomes nutritional. Short and plump becomes
endocrine pattern. And correct.
He is not short for the family as well.
So he is short for the family.
He is short for the family. So minus 1.41. And corrected height SDS?
Minus 4.27. Definitely he is short.
Very, very short. And height SDS for bone age. So he's short for the bone age. So he's pretty much everything. He's short for the population. He's short for the bone age. He's short for the family. And he is heavier than his height. You can say that. So this is a short and plump child. So this classically suggests that we are dealing with a case of endocrine pattern of growth failure. So this diagnosis of celiac is wrong. So what do you think was wrong in this case?
So TTG is 32, sir.
So we should have done something?
We should have done the IGA level as well.
So we should have done a biopsy to confirm that this is really celiac before you start the growth hormone. So if you really look at in terms of basic interpretation, you will get the right picture. Now we have a second scenario. Child is very, very fat. If you can look at weight is 127, height is 167. So obesity is also a very common condition. Now 5 to 6% may be actually obese. Most of them are physiological. 98% of children with obesity are physiological. Only 2% will have a disease. So it's even more important than short stature to be careful about that. And you need evaluation. So when we talk about obesity, what are the parameters which will tell you that this is physiological versus pathological obesity?
So we have to look for the height, the development, the pubertal status. That will help in differentiating the pathological.
So normal growth, normal puberty, normal development would mean this is physiological. If you have compromise of these, you start thinking of a pathological cause. So the most important thing to look at in a short child is the weight. Short and plump, endocrine, short and lean nutrition. The most important thing to look at in an obese child is the height. Obese and tall is constitutional. Obese and short, again, you go to endocrine cause. So pathological causes, if you have very early onset with hyperphagia, visual abnormality, syndromic features, start thinking of genetic causes. Of course, if there is drug history of steroids, valproate, you will get hyperphagia. And endocrine causes are extremely rare causes of growth failure. In our own study, it's only 10% of all causes will be having a pathological cause. So even in a referral center, only 10%, but in a pediatrician, it will only be 2%. So growth, pubertal delay will give you a clue. So what will be your approach for obesity?
So first we have to see whether the what is the weight of the child. If it is more than 97 percentile, definitely the child is obese. And if there is no, the child does not fit into the obesity criteria, then we need not to do any workup. And if it fits, then we have to see what is the age of onset. Than 5, definitely the BMI plays an important role, and when the BMI SDS is more than 3, then definitely for the child less than 5 years, we have to go for the genetic workup in this case. And when in case of less than 5-year child and the BMI is less than 3, we need to look for the syndromic features in the patient, and if there is a abnormality in the development, there is a vision problem, or there is any dysmorphism in the facies, then we should go for the genetic studies. And when the height, when there is no syndromic features in the child, and then we have to look for the child is tall or short, and if the height SDS is less than 0.5, then the endocrine workup is required. And if it is less than minus 0.5, then definitely we need to screen for the complications like blood sugar, lipid profile, and BIA.
So most important parameter, of course, is to look at what is the age, what is the severity, and other growth, which will give you the criteria. So based upon this, we have developed a obesity interpreter, which provides comprehensive guidance based upon simple parameters. And again, we have found that a large number of it has got huge concordance. And as you can see, 92% actually, this is the precise figure, 92% actually had a physiological cause. So even from an endocrine center, 92% are physiological. This is something, a big message. Now we have a 12-year-old boy who is height of 160, weight is 70 kg. Parents are not very tall. The bone age is all right. Now this child comes to you with a TSH of 7.91 and has been started on thyroxine. Do you agree with this or not?
So first of all, the child is obese. As we can say, he's having 70 kg of weight in 12 years, and the TSH is 7.9. So definitely we cannot rely on this TSH. We need a FT4 level as well. And if we use the obesity interpreter in this child, we'll see that BMI SGS is more than 27 kg per meter square.
Yes. So he is obese, but is he short and obese or tall and obese?
So as we can see in the interpreter, the height SGS is 1.7. So child is definitely not short. Weight is 2.51. Definitely he has
this is clearly
obese child.
Is tall. So it is unlikely to be thyroid, and this is the effect of obesity,
not the
cause of obesity. So borderline cases, you may do a TPO. Mostly it will be negative. You don't need to worry about. 12-year-old girl, similar age, but she is short and she looks obese. Her basic tests were normal and she had a rapid weight gain. Now, if you look at this growth chart, what do you think, Vibha?
So here we can see the height is much more effective. The height age is lesser than the weight age. So here we can say the child is short and plump. So this is more going to the favor of endocrine pattern.
If you look at the output from our pathological obesity. So again, key things to look at. So what obesity interpreter does is that makes life very simple as to you don't want to miss on cases. And this actually turned out to be a Cushing syndrome. So you should always be wary about a pathological cause in that perspective. So thanks a lot, Vibha, for this wonderful discussion. And we will now be carrying forward. And if there are any particular questions which are there with regards to these parameters, we'll see if they are there. So if there are any questions, you are always free to post them in a Q&A or the chat. And at the end of the session, we will discuss in each group. So we have gone through growth. We will now be moving towards the second aspect, which is with regards to the glucose disorders. And glucose disorders are also very, very important because they can come as an emergency. So when we talk about diabetic ketoacidosis, it basically means that you have diabetes, which means hyperglycemia. You have got a ketosis and you've got acidosis. So all three parameters become important. So in cases of insulin deficiency and counter-regulatory excess, you will have multiple effects. The major effect of insulin deficiency is the increased lipolysis and ketogenesis. So you will be producing more ketones, which will then cause acidotic breathing, rapid breathing, abdominal pain, and abnormal odor. On the other hand, this combined with a counter-regulatory excess will cause hyperglycemia, and this hyperglycemia will then lead to loss of a lot of substances through osmotic diuresis. So you will have loss of sodium to the tune of approximately 4 to 6 milliequivalents per kg, potassium 2 to 4, and a lot of water loss. So you will have dehydration, which will happen. Now, once you treat, and the most important treatment initial is fluid. Once you give fluid, the volume expands. The counter-regulatory hormones go down. So what it means is that your glucose will come down by around 100 milligram per DL just by giving fluid. So at this stage, you do not need to give insulin. If you give insulin, it will cause a very rapid fall. Subsequently, you will give insulin, which will cause suppression of ketogenesis. And that's very, very important from that perspective. Now, if you give too much fluid, you are at risk of causing cerebral edema. If you give too much fluid, you can also cause hyperchloremic metabolic acidosis. If you give too much insulin, you will also cause hypokalemia because insulin suppresses the potassium levels. So this brings us to the complications. Most dreaded complication is cerebral edema. typically a marker of severe disease, fluid intake, soda bicarbonate, and osmotic shift. Now, Western countries are now saying that this is part and parcel of DKA. So you may not have any osmotic shift, still you will have cerebral edema, which may be true because once your levels have become much better, you don't have any fluid issue, that issue will become there. Still somebody will develop cerebral edema because of a hypoperfusion, reperfusion injury. But in resource poor countries where managements are not always protocolized, this osmotic load also becomes important. So we should not ignore that. And that is also important. This is the most common cause of mortality and morbidity. The key thing we can do is to give less fluid and slower correction and identify it early and treat with mannitol. So a child who has been treated outside with fluids, somebody who has a very severe acidosis, pH below 6.9, CO2 level which is less than 10, GCS which is below 15 at admission, I would be very wary that this child has cerebral edema. Maybe treat right away or maybe start in a very slow manner in terms of management. Second scenario will be hypokalemia, which if present at admission is a dire emergency. In that scenario, if you do start insulin, you will cause a huge problem. So you have to give potassium right in the infusion phase. Otherwise, insulin therapy will cause this hypokalemia. The third complication is acidosis, which is largely because of ketosis. In our experience, this DK, even if it's severe, will resolve by around 12 to 18 hours. Ketosis will resolve quickly, acidosis after 6 hours. But if it's persistent acidosis, think of infection or hyperchloremia as a possibility. There is no role of soda bicarbonate in DK unless and until a child is dying because of hyperkalemia or there is severe cardiac compromise. That is where you will need a bicarbonate. High risk of atypical infections, including bacterial and mucormycosis may be there. There is a risk of thrombosis, so never put in a central line unless essential. If you are putting it, give a low molecular weight heparin and be wary of rhabdomyolysis. So sudden onset pain in the legs, redness, red colored urine, decrease in urine output, decrease in the or increase in potassium levels, start thinking of rhabdomyolysis as a possibility. Now, cerebral edema typically in the Western picture is known to occur later and happens after 12 hours to 24 hours. Our studies show that there is a high risk of cerebral edema right at diagnosis, and children who have a more severe form of disease, who have been treated outside and who have a low CO2 at admission at a very, very high risk. So you have to be careful about that. So now I'll invite Alapan to talk a bit about the management before we go ahead with our tools and how do we assess.
As with all emergencies, the management of the decay based on the initially the ABC protocol, that is the airway, breathing, and the circulatory status. So initially a child when presents to us with diabetic ketoacidosis, if he is obtunded or in severe coma, we must not forget to secure his airway. We can put a nasogastric tube in this scenario to prevent the aspiration of the gastric content. But one must remember that intubation in this setting is not usually advisable, as during the intubation, you may increase the PCO2 level, which may further worsen the cerebral edema. One must avoid this unconscious patient to put any drinks in his mouth or something like that. And there should be 2 wide bore lines should be secured, one for the fluid therapy and another is for the insulin therapy. But one must be very cautious about putting the central venous line in this perspective, that there is a huge chance of development of thrombosis in these patients. Oxygen must be given to the patients where there is a development of shock. And if, as I have already described, that intubation is avoided, as well as the central venous line due to the increased chance of thrombosis. So one must be very cautious about the fluid therapy, so that there should not be any fluid overload, so that it may further accentuate the chance of cerebral edema in the setting of DK. So the initial management part, it is the hydration part, and it is within 24 to, usually it resolves by 24 to 48 hours, and it has 2 components. Like one is the maintenance fluid, and according to the ISPAT guidelines, it is a 4-2-1 rule. That means in the first 10 kg, you will give 4 ml per kg fluid. In the second 10 kg, you will give 2 ml per kg, and the subsequently 1 ml per kg fluid, and the deficit fluid. But due to this increase in the counter-regulatory hormones, it is always difficult to assess shock in this in the child, and it is very difficult to assess the dehydration also. So there is another guidelines used by the British BESPED guidelines, that is showing using the pH cutoff to classify the dehydration. Normal saline is the fluid of choice, but the fluid should not be more than double maintenance, and we used to advise to maintenance, the fluid should be around 1.5 times of the maintenance fluid. In case of obese children, it is very difficult to assess the fluid volume, how much fluid should be given. So we use a body surface area to further evaluate for that. Plasma light or Hartmann solution are the other options apart from the normal saline, and there is a less chance of hyperchloremic acidosis in that scenario. Now the treatment of insulin, it is ideally should be given in the intravenous route, but there is a setting where you can't access the IV you can't secure the IV line, or IV access is difficult. You can go through the intramuscular route, which has a different dose of 0.3 unit per kg 4 hourly. The dose of the IV insulin is 0.05 to 0.1 unit per kg per hour, and there is no proper guidelines whether we have to start with the 0.05 or 0.01. And insulin is very sticky to its tubings, and so one must flush the insulin tubes and the container before using the insulin therapy. And one must remember that insulin change must be very slow, because if we change the insulin very rapidly, there is a huge chance of fall in the glucose level very rapidly, and there is this osmotic disequilibrium in our body, which may further lead to cerebral edema kind of picture. Insulin is usually diluted 50 units in the 50 ml of normal saline. Over dilution is usually avoided. So what we want to monitor here in diabetic ketoacidosis, one must monitor about the consciousness, level of consciousness in the patient, and we have to be very cautious about the cerebral edema. If there is any decrease of the level of consciousness, we must act rapidly. There should be improve of the dehydration status of the body, and one must monitor very cautiously about the urine output, as decay might precipitate into renal failure. The urine output must be greater than 1 ml per kg per hour. The corrected sodium level must be stable. If it falls rapidly, it may further puts into cerebral edema. And during insulin therapy, there is a huge chance of life-threatening hypokalemia, which should be observed. Ketoacidosis, as Sir has already described, is usually resolved around 12 to 18 hours, even if it is a severe disease. So we have to check for whether this acidosis part is resolving or not. Now the important, one of the important intracellular ion, and very important in the perspective of diabetic ketoacidosis, is serum potassium. There is an increased chance of decrease of the serum potassium during insulin therapy, and one must be very cautious about the insulin level during the treatment of with insulin therapy. By our guidelines, we say that if potassium level is less than 3.3, we should defer the insulin therapy, and we should add insulin in the hydration fluid. If the insulin is between 3.3 to 6, we can add 40 millimole insulin potassium in the fluid, and if it is above 6, we should check for the urine output whether it is present or not, and if it is not present, we should avoid the potassium therapy in this scenario. The pointers towards the low hypokalemia are the polyuria and the myopathy, and intervention, we should give potassium with IV fluid. Also, we can reduce insulin. In case of very refractory state of hypokalemia, one can consider magnesium in that scenario. Now dextrose, as already it has been discussed, that if the glucose level falls very rapidly, there is chance of this osmotic change, and blood glucose, it may leads to cerebral edema. If the blood glucose level during treatment is more than 300, there is no need to add any dextrose fluid. But if it is less than 300 and between 200 to 300, and less than 200, one must add 5% and 10% dextrose subsequently. Now the bicarbonate therapy, bicarbonate, that is, but the acidosis part, one must check for the acidosis part whether it is resolving or not. And we should check the ketone levels. If ketone is more than 2, there is always possibility of ketoacidosis. But if it is less than 2 and still there is presence of acidosis, we must check for the chloride load, which is calculated by sodium minus chloride minus 32. If chloride load is less than 32, one must suspect the lactic acidosis. And if it is more than 32, there is increased chance of hyperchloremic acidosis, which is due to excessive chloride in chloride containing fluid in the infusion. So anion gap is usually, normal range is 10 to 12, but in case of diabetic ketoacidosis, it is usually in the range of 20 to 30. If the anion gap is more than 30 or 35, then one should suspect that there is a concomitant lactic acidosis that is going on. This hyperchloremic metabolic acidosis is self-resolving. And regarding the bicarbonate therapy, as Sarah has already discussed, one must not use bicarbonate. And there is only 2 indications where we can use this bicarbonate therapy. Number 1 is whether there is life-threatening hyperkalemia, and in the setting of a severe acidosis where there is this cardiac compromise is present. Now the bicarb infusion is usually given around 1 to 2 ml per kg. Another important intracellular ion is the phosphorus, and there is an increased chance of hypophosphatemia, and there is a severe risk that this hypophosphatemia can lead to rhabdomyolysis and further progress into acute kidney injury like state. So we must check for the phosphorus level, and if the phosphorus level is less than 1, we must add phosphorus in the fluid with along with the KCl. If phosphorus level is more than 1, we must monitor. As we have already discussed, the features are like altered sensorium, the muscle pain, or due to rhabdomyolysis, there is altered coloration of the urine, and ultimately it may lead to acute kidney injury. The treatment is the KPhos is added to the fluid 50% with KCl 50% along with this. We must check for the calcium level in that regard. Now,
so I think you very correctly mentioned about the various parts. The most important part which often people forget is phosphorus. So phosphorus deficiencies may be lethal. It's a major cause of renal injury and renal insult. So as you said, the first phase in management is just hydration. You give fluid. So don't worry much about, don't do too much calculations. Of course, we're going to help out in terms of calculation, but otherwise we just give 10 ml per kg of normal saline. Then you calculate deficit and maintenance typically over 48 hours. If you have a very high risk of cerebral edema, like severe metabolic acidosis, very low CO2, low GCS, corrected over 72 hours. And then you start insulin at 0.1 unit per kg per hour and add potassium in everybody unless they have anuria or hyperkalemia. If your blood sugar goes below 300, you add dextrose, as we already discussed. Very importantly, don't use soda bicarbonate and be monitoring for cerebral edema. So when we talk about management of DKA, if you do too little, you may have a problem. If you do too much, you may have a problem. So if you give less fluid, you will have more dehydration. You will have a gradual correction. If you give too much fluid, you will have cerebral edema. If you give too little insulin, you will have gradual correction. If you give too much insulin, you will have hypokalemia. So Alapan, will you prefer to have a gradual correction, more stay in the ICU, or cerebral edema or hypokalemia and death?
No, sir, we will obviously encourage for the gradual correction.
So that is why the mantra of DKA for the last 10 years or so is clearly go slow. You may do more harm by being more aggressive. So going slow is the most important part to remember. And having been teaching this DKA part for the last couple of decades, I've still realized that despite of all the sessions, our residents were making a lot of errors in terms of management. So over 70% of cases, there were errors which were happening despite a written protocol and despite everything. And this error was not just benign. If these errors are happening in the first few hours of prescription, they will cause hypoglycemia, they will cause hypokalemia, and they will cause dehydration. So what can be done to prevent that? And this led to the development of our mobile application-based DKA tool, which basically guides both initial as well as subsequent management. So whatever Alapan has been talking about, whatever my videos are talking about for hours, it's everything summarized there. It will tell you how much fluid is to be given, what rate, how to monitor. And very importantly, based upon the hour of admission, we then also guide about subsequent management as well. So a lot of these calculations are not left to guess, not left to mistake. This is the precise, and you will improve the outcome in that perspective. So we'll start off this case now. 540 blood sugar. There is a metabolic acidosis. Potassium is 5.8. How would you like to proceed in this case, Alapan?
So as you can see, this is the pH is 6.9 and the dehydration is 10%. So we'll take this as a severe decay, and we'll go for the first the bolus dose of 10 ml per kg in the first 1 hour, and subsequently the maintenance fluid. But in this case, I would like to go a bit slow because of this pH of 6.9. So there is an increased chance of.
So that's why what our algorithms which are feeded in the application will tell it that you have to give a slower correction. So it's using 111.7, which will correct over 72 hours. So this becomes important. And it clearly says that insulin should also be started. Of course, you have to add potassium as well, because some people say 5.5, but we will say 6 will be a criteria as far as the potassium is concerned. Now, based upon your treatment, at 8 hours, blood sugar is 180 and base excess is -12. Are you happy?
The blood sugar has come down, but there is still presence of this acidosis, but we have to check for whether this acidosis is for this hyperchloremic metabolic acidosis or any other reason is there.
Do you expect acidosis to go off in 8 hours? That's my question.
No, there should be a long time.
So glucose comes down in 6 hours, ketones comes down in around 12 hours. Acidosis, if it's this severe, will never come down in 12 hours. It will take up to 18 hours. So this is known. Your hyperglycemia has come down. Acidosis is persisting. What will you do?
So we have to check for the whether first of all we have to add for the blood, as the blood sugar is 180, we have to add dextrose 10%.
This is the time you don't expect acidosis to go, so don't worry. You add dextrose. So this is the concept, and if you use our follow-up interpreter, it will based upon these inputs, it will tell you, okay, it's the time you change intravenous fluid to N by normal saline 10% DNS, and of course monitor for other things. Now, what it is also telling is very interesting. It's saying fall in corrected sodium. Watch for cellular edema. So if you give your sodium values, it is automatically calculating what is happening to sodium. So it's actually your monitor as well. So it's not only giving you consultation, but also monitoring, and it's triggering you, okay, there is a high risk of cellular edema. It also tells you that, okay, urine output is fine, urine output is low. So what it's saying, check hydration, block catheter, and renal failure. So it's so many algorithms are fitted here, and you get precise output based upon that. So if you use this app, you will have significant improvement in terms of the quality of care. And why is it important? Because first hour of care is most important. First 4 hours is very important. So these golden hours should not be lost. And that's why this app will help you. Now, 20 hours, now your blood sugar is okay, but your base acidosis is persisting. Now, are you worried?
No, I'm not worried about this thing. We have to check whether we have this ketone is still present or not in the scenario. If ketone is not present, we have to consider of hyperchloremic metabolic acidosis, which is self-resolving. So we not.
So this is the lag between ketosis and acidosis because of lot of factors. And as you said, very important is hyperchloremic metabolic acidosis. So in this case, your ketone is negative, anion gap is basically low, which means it's a hyperchloremic metabolic acidosis. You do not need to worry about. You just follow up, and it says likely hyperchloremic metabolic acidosis. You can now taper, because how long will keep on continuing insulin? If the urine output is good, don't worry about this, and this will take over from that perspective. So hyperchloremic acidosis. Now post decay, he was started on a sliding scale 2 units per kg per day, fluctuating sugars. And why would you like to? What is the problem in this management of sliding scale?
In the children, we do not prefer the sliding scale. Rather, we prefer to mimic the physiology of the pancreas using the basal and bolus regime.
So sliding scale is more of a reactive one. You just give it, depending upon sugars will go all over. So you should switch to basal bolus. How much dose will you recommend for this child?
In the post-decay phase, the child is already in puberty, so a higher requirement around 2 to 2.5 unit per kg per day.
So best to start basal bolus, and we have to start at a higher dose. So based upon our calculator, if you look at these parameters, which looks into puberty, weight, and decay, it is actually saying a very high dose of approximately 2.5 to 3 units, like 90 units. So this may be required in the initial phase. So this is another tool to go forward. So we have talked a bit about decay, and that we'll just touch base about hypoglycemia on that, and then we'll go to the next session. So hypoglycemia basically means that your blood sugar levels are low. There are only two reasons: either you are not producing enough glucose or you are utilizing more. So if you have a problem in production, if you give the physiological replacement dose of 6 milligram per kg per minute, this will take care of it. If it's increased utilization, you may need a much higher infusion rate of approximately 12 milligram per kg per day. These substrate defects may be because of prematurity or SGA, or metabolic effects because of endocrine causes, in which case you will have micropenis or midline defects which will be there. Then you may have a metabolic defects like galactosemia, in which you will have hepatomegaly onset around 3 weeks with hypoketotic pattern, and cataract will also be a clue. Increased utilization could be because of sepsis or cardiac failure, which will be very evident to you, or most commonly because of hyperinsulinism, which is the most common form of persistent hypoglycemia, which is typically non-ketotic. It may be because of maternal diabetes or beta blockers, lasts around 1 week. It may be prolonged 6 to 8 weeks because of a hypoxia or a SGA response, and this prolonged hyperinsulinism is the most common cause of hyperinsulinism which you will encounter. They will have a low birth weight rather than macrosomia, and they will improve over 6 to 8 weeks with diazoxide. And finally, you may have genetic causes with severe macrosomia requiring lifelong therapy. So once you have hypoglycemia, the body will respond with every way to correct it. So what it will do is that it will inhibit insulin. So you should have zero insulin when you have hypoglycemia. You should have a ketone response. Everybody with hypoglycemia should produce ketone unless there is hyperinsulinism, fatty acid oxidation defect, or problem in the galactosemia or fructose intolerance. So ketone should be more than 2. Your growth hormone and cortisol levels should also be sky high. So don't compare a normal range. A normal growth hormone and a normal cortisol during hypoglycemia is inappropriately normal. It's low. This means there is deficiency, and of course lactate should also be low in that perspective. So if you really look at these parameters and what we call as critical sample, you will get the right answer in that regard. So any detectable insulin in this hypoglycemic phase is hyperinsulinism. Non-ketotic, you have to suggest of specific causes. I discuss hyperinsulinism being number 1. If your lactate is high, you're dealing with galactosemia and gluconeogenic defect. And if your growth hormone and cortisol are normal or low, it is multiple pituitary hormone deficiency. So the key parameter, of course, is ketone. If your ketone is low, only hyperinsulinism, fatty acid oxidation, maybe add galactosemia there. Lactate high, you are dealing with GSD1 or fructose 1,6 bisphosphatase deficiency. pH acidosis, again, you add organic acidemia there. And insulin, if it is detectable, is hyperinsulinism. And then glucagon response is required in certain scenarios. So the approach is, if you have hypo or non-ketotic hypoglycemia, reducing substance being positive, it is galactosemia. Negative, look at insulin. High or detectable levels suggest hyperinsulinism. Otherwise, it's a fatty acid oxidation defect. If your ketone is high and lactate is also high, you have got a GSD1 or gluconeogenic defect. If your lactate is normal and there is a large organomegaly, this is the rarer GSD variant, GSD 3, 6, and 9. If they are not there, look at cortisol and GH. If they are low, it's pituitary defect. If they are normal, it's accelerated starvation. So basically, we're looking at ketone, we're looking at lactate, insulin, urine-reducing substance, you will get the diagnosis. So when you talk about critical samples, take the samples, but don't process all immediately. Process as and when required in that regard. So now, Alapan, you can come back. 3-week-old boy with seizures, sugar is 28, ketone is 2.3, sodium is 128, potassium is lowish, lactate is normal. What are you thinking about in this regard?
So in the setting of a hypoglycemia, there is production of the ketone. So this is ketotic hypoglycemia. So I would like to see.
And there is something else.
Lactate is low.
And
low sodium. There is
hyponatremia. So
hyponatremia.
if you forget about algorithm, hyponatremia, hypoglycemia, what are you thinking about?
And this is something like a cortisol deficiency or
so a multiple predatory hormone deficiency, because a single hormone deficiency is usually not sufficient to cause hypoglycemia. So now we've got a specific approach pathways which talk about when do you want to evaluate. So they go step by step, and it's basically saying your GIR is low, and as you said, your ketone is more than 2. In this regard, your cortisol level becomes important. So what we are finding, he also has micropenis. So this is multiple predatory hormone deficiency. Now, in this regards, the second case is again a 3-week-old boy with failure to thrive, hypoglycemia with a low GIR with hepatomegaly. Now, what are the causes of hepatomegaly with hypoglycemia in the newborn period?
In the newborn period, if a child presents with hypoglycemia, hepatomegaly, there could be chance of hyperinsulinism possibility. There would be galactosemia if it is present or not. It could be
GSD1?
No.
It does not
present hypoglycemia in the neonatal.
Beckwith-Wiedemann syndrome is another possibility. So yes, now you will like to look at what?
I would like to look whether it is ketotic or non-ketotic.
So it becomes important. So it's persistent. So you will evaluate for hypoglycemia only if it's persisting beyond 48 hours or your glucose requirement is more than 12. So in this regards, ketone is negative. So low glucose requirement, non-ketotic. Is it hyperinsulinism or is it more likely to be galactosemia?
It's more like to be galactosemia because the infusion rate, the requirement is less.
So reducing substance was positive, so this was galactosemia. 10-day-old girl with hypoglycemia, GIR is 14. Now, of course, you start thinking whether you need to evaluate or not. So more than 2 days, anybody who is above 2 days of life has no business to have hypoglycemia. All these transitory things happen in the first 48 hours. So you didn't require evaluation. Ketone is negative. So what are you looking at here?
Is non-ketotic hypoglycemia
with high
GIR rate.
So it's very, very characteristic.
Of hyperinsulinemia.
Reducing substance is negative. Insulin is 3, which is reported as normal.
But this is detectable in case of hypoglycemia. So this is
clearly hyperinsulinism. 6-month-old boy with lethargy with blood sugar of 36, ketone positive. So now we talk about older individual, ketotic, and he has got lethargy and high lactate. So differentials?
Differentials are 3. It could be a GSD type 1, gluconeogenic defect, or organic acidemia can present sometimes.
Yeah, a bit unlikely, but yes, they may. Hepatomegaly is huge. Now your differentials become less. GSD1 versus a gluconeogenic defect. And here, of course, if you look at this, this is a non-ketotic response and your lactate level is high. Now your differential is very less. You're basically looking at a GSD in this scenario. 1-year-old girl not waking in the morning, blood sugar is 24, doesn't have a hepatomegaly, and the ketone is strongly positive. Lactate is normal. So what are you wanting to do now?
This is ketotic hypoglycemia with no organomegaly, and there is less lactate is negative. So I want to see the GH and cortisol level in that scenario.
So this is, you're thinking go more towards the accelerated starvation, but you have to first exclude GH and cortisol. So growth hormone and cortisol are very, very high. So this makes them unlikely. You have to think of more of a accelerated starvation or ketotic hypoglycemia in this regard. So thanks a lot, Alapan, for this wonderful discussion about glucose disorder. There are a couple of questions which we will take before we go ahead. The next session, we have got Dr. Randa, who is calling, can I use this app among the Jordanian population? Yes, in terms of all the other algorithms and pathways are for the general population. The app predominantly till 5 years of age uses the WHO criteria. Subsequent to that, there is an Indian ethnicity which is used. But in the next version, we are going to have the WHO criteria. So this can also be used across the various population. Now, Dr. Randa is again asking how much potassium should we add if it's less than 3.3. So less than 3.3, first thing is don't start insulin. And in the first normal saline that you're giving as a bolus, add 20 millimoles per liter in that regard. Subsequent to that, depending upon your potassium, you can then decide about the protocol. Dr. Priska is asking, ISPAT guideline recommend deduction of fluid bolus when calculating maintenance fluid? Yes, we do practice the same, and our the guidelines, actually the app which says it automatically deducts the bolus which has been given, and it also asks about whether the prior fluid has been given or not, and it deducts that also. So that's an important point, Dr. Priska, who has highlighted that. So we have gone through two big topics of growth and glucose. So this is more of a rapid fire, more like a 2020 match rather than a test match, because we are trying to cover a lot. But the main aim is to give a basic concept and see how we can implement that in clinical practice. So we will now be moving forward towards the third group of puberty and DSD. So pubertal disorders basically are extremely important, and for understanding we need to understand the physiology. So when we talk about physiology, there are three major organs: the hypothalamus, the pituitary, and the gonads, which are the testes and the ovaries. So you've got GnRH, LH, FSH, and estradiol and testosterone. Now, LH and FSH have separate effects on the testes and on the ovaries. The most important gonadotropin in boys is LH. The most important gonadotropin in girls is FSH. LH deficiency in boy will cause complete absence of pubertal development. FSH problem will cause infertility. Complete absence of FSH action in a girl will cause zero development, so complete delayed puberty. Complete absence of LH receptor action will cause anovulation. So this is how you need to understand the difference from that in that perspective. There are peripheral players like adrenals, which also produce androgens, causing contrasexual precocity in girls, as well as causing precocious puberty, which is peripheral in boys. Adrenals also give an important clue in terms of etiology of delayed puberty. So if your both adrenarche and gonadarche are suppressed, you are dealing most likely with a multiple pituitary hormone deficiency or a constitutional delay of puberty and growth. While if you have a normal adrenarche with absent gonadarche, that means you have pubic hair but no breast development, you think about a possibility of a central cause, a hypogonadotropic hypogonadism. So precocious puberty typically means that you have a problem in the central axis. Here your LH levels will be high. In boys, you will have enlarged testes beyond 4 ml, which will give you a clue. Most cases will be idiopathic, but if you have a girl below 6 years of age, and if you have any boy with precocious puberty, you have to think of a pathological cause. Peripheral could be because of testes, ovaries, or adrenals, much more common in boys as compared to girls. In this scenario, in boys, you will have a small testis, which will indicate a peripheral etiology with a LH, which is undetectable. Delayed puberty is more of an act of omission. Problems which are act of commission, which problems are happening in the hypothalamus, hypogonadotropic hypogonadism. Most common causes constitutional delay of puberty and growth. When you say CDGP, everything is slow. You will have no pubic hair, you will have slow growth, but they would have a normal mini puberty. So they will have normal penile size. So in boys context, if you're thinking of a boy with CDGP, typical case will be short, family history of delayed puberty, no pubic hair development with a normal penile size, no anosmia, no neurological features, and that will give you a clue in that regards. LH will be low. While if you have a peripheral cause, typically you will have hypergonadotropic. The most important parameter to look at will be FSH. So most important investigation in precocious puberty is LH. Most important investigation in the delayed puberty is FSH, which will give you a clue in that regards. Now, precocious puberty is much more common in girls, or I would say the girls are more likely to come to you with even slighter normal variants of precocious puberty. 90% will be physiological. In boys, you will have higher chance of pathology. So if you have a boy with precocious puberty, and on the contrary, you have a girl with delayed puberty, you should worry more than if you have a girl with precocious puberty and a boy with delayed puberty. So the chances of pathology become important in that regard. So we can have a few, Dr. Dhwani, you can come up and start off the discussion from here.
Thank you, sir. So, precocious puberty in girls is basically, puberty in girls is basically defined by puberty, puberty, and menarche. Puberty before 8 years or puberty before 8 years is considered precocious in girls, and menarche before 9.5 years is considered precocious. If we were to compare the etiologies based on the puberty and puberty,
So no thelarchy, but presence of pubarchy. This goes in the lines of an premature adrenarchy. If we have no thelarchy, no pubarchy, but vaginal bleeding, then one must think of a local cause. If you have thelarchy but no pubarchy with vaginal bleeding, think of hypothyroidism importantly, that is the Van de Grunbach syndrome. And in a girl with thelarchy as well as pubarchy, one must think of a central precocious puberty. There are also incomplete forms of precocity which may be seen in girls. There may be an isolated thelarchy, which is often isolated, seen commonly in 1 to 3 years of age group. However, even in such cases, one needs to progressively follow them up for development of other features of puberty. Isolated puberty can also again be idiopathic, especially in the setting of an SGA child with rapid catch-up. But one must be wary of adrenal etiology that is producing more androgens and causing this puberty, which is this virilizing forms of CAH, which may be picked up at this age, or an adrenal tumor, which is more sinister. Isolated vaginal bleeding, one must think of trauma, tumor, or abuse, which has to be ruled out in this setting. So, when approaching a child with precocious puberty, one must look at the extent of puberty, that is. If it is an isolated puberty, one must go for the DHEAS levels. Levels less than 40 micrograms suggest isolated puberty, and nothing needs to be done in such cases except following them up. Levels 40 to 135 microgram per deciliter suggest an premature adrenarchy and possible insulin resistance, which may require treatment in that setting. However, much higher DHEAS levels, more than 135 micrograms per deciliter, need workup for an adrenal pathology, especially a CAH or adrenal tumor. If there is only an isolated vaginal bleeding, one must look for a local cause. And when the puberty is complete, or someone who presents to you with a thelarchy, it is more likely to be an isosexual precocious puberty. The most important or first investigation that one needs to look at is the bone age. If that is retarded, one must think of hypothyroidism and get a thyroid profile done in that setting. If the bone age is normal for chronological age, it could very well be a slowly progressive precocious puberty, especially seen in the 6 to 8 years age group in girls. Whereas if the bone age is advanced, look at the LH levels. If the LH levels are pre-pubertal, that suggests a peripheral production of testosterone or estrogen, and one needs to go for a peripheral imaging. Whereas if LH levels are elevated, this suggests a central precocious puberty. An important thing to look for is that MRI needs to be done to rule out a central pathology in girls less than 6 years old.
We'll start off with the first case, 2-year-old girl with thelarchy, and precocious puberty is very common at this age group, and a lot of presentation will happen. Onset at 6 months ago, it looks like the parents said this looks like a slowly progressive. So first thing you would like to ask is whether the initial thelarchy has gone off or not, or it's a new onset. That is another thing to look at, and of course, it's slowly progressive. B3, P1, M0. So what do you think here in terms of the cause, Mani?
Now, because there is no waxing waning case, however, in a 2-year-old, one must consider a peripheral cause as well. But in the absence of a waxing waning case, it could very well be an isolated thelarchy, which is common at this age. So one should look at the LH
I think
levels.
the big thing here is that if you have some form of a very early onset organic central pathology, it's a very progressive disease. You would have menarche typically by 2 to 3 years of age. Similarly, if it's McCune-Albright, you would not have a long-term breast development without bleeding. So this 2 pointers will suggest more like a isolated thelarchy. She is having a normal height. There's no cafe on a spot. So what are you thinking now?
Looks like an isolated thelarchy. I would like to, however, observe this child for progression.
Would you like to do some workup as well?
Yes, the LH levels.
So we should definitely document, even if you're thinking, you cannot just reassure the parent, and you know yourself also, because there's a 10% chance you may be having the start of precocious puberty. So if you go by our puberty interpreter, in which you just have to enter what is your breast stage, your age and height, it tells you, okay, you do these basic workups. You don't need to really worry about that, but do a workup. And what we found here is that your LH is low, but FSH is high. There is a very concern about this FSH value.
This is expected in the given age
So
group.
you tend to have a high FSH in this regard. Then ultrasound showed a small cyst, which was the microcystic appearance. So your diagnosis of isolated thelarchy was right in that situation. So you need to follow up. Now, 6-year-old girl with thelarchy for the last 1 month, and she looks tall for her age. Pubic hair is stage 1, B3, and bone age is 11 years. Is this isolated thelarchy?
No, sir. Not only does the child have a thelarchy, there is also an accelerated bone age and height age, suggesting that the child, this is probably a central precocious puberty. We need to get the LH and estrogen, LH-FSH estrogen levels.
So
in
this
child.
looks like a progressive one because it's a very early onset and rapidly progressive. If you look at our interpreter, you're saying breast stage 3 and you're saying no pubic hair and the height is advanced and bone age is 11 years. Clearly, it will indicate that you would need a workup. It's most likely a rapidly progressive precocious puberty. So this, what we try to do is through this parameter is to be able to decide about whether it's a slowly versus rapidly progressive, normal versus abnormal puberty, whether you want to do evaluation or not. So in this case, you need to treat. 6-year-old girl with pubarchy who was normal birth weight, height seems to be high for this girl. There is no breast development, but there is stage 3 pubic hair development. Is this a normal idiopathic pubarchy?
No, sir. One would not expect such severe acceleration in the height SDS with simple precocious pubarchy. There needs to be evaluation for a more sinister cause, especially of an adrenal etiology in this setting.
Yeah. So clearly in this scenario, if you're looking at stage 3 pubic hair development in a tall girl, you have to think of precocious pubarchy. And I would go a bit step further that will diagnose based upon the DHEAS level, whether it's most likely to be an exaggerated adenarchy. So DHEAS is 240. What do you think here now?
So it is definitely in the highest most range. So 17 OHP levels and adrenal imaging become important here.
So what we're trying to say is that if you have a SGA child who has some mild development and who is not very tall, you can say, okay, this looks more likely to be a isolated pubarchy, but this is more likely to be an exaggerated scenario. 7-year-old girl with vaginal bleeding, single episode, no breast, no pubic hair, vaginal mucosa is red.
So a red vaginal mucosa suggests no prior estrogenization. Therefore, this vaginal bleeding is more likely secondary to a trauma, infection, or an abuse.
So most likely a local cause.
Yes.
Again, our interpreter will again give you the clue that you have B1, P1, and your height seems to be all right. So this girl clearly is a isolated bleeding. You do not need to do a workup. And the workup was done basically just to prove to the parent that nothing is to be done. It was normal and referred for a gynecologist. 7-year-old girl again with thelarchy, but here she is short and she has got no pubic hair and she has got a lot of breast development and vaginal mucosa is pink. What do you think here?
So as we can see, she has a breast stage 3, a severely compromised height and estrogenization of mucosa. In the setting of a precocious puberty, one expects an accelerated height. However, when the child is short, even in the setting of precocious puberty, one has to consider hypothyroidism in this setting.
So any girl who is short with precocious puberty, short with ovarian cyst, always think of hypothyroidism as a possibility, and bone age will give you a clue in that perspective. And again, if you really look at these parameters, you will be able to consider the possibility here. So once you diagnose this, the next issue is in terms of management. So most scenario would be to use a GnRH analog. If it's clearly a central precocious puberty, you will use GnRH analog. There will, however, be an initial flare response. So do not treat everybody with GnRH analog if the onset is below 6 years of age and 6 to 8 years of age with progressive puberty, then you should treat. So this will basically desensitize the pituitary. Continuous exposure will cause the levels to go down. So you have preparation which can be given every 4 weekly, 12 weekly, or even annually, which will help you out in this scenario. Now, adherence becomes important because every time if you're non-adherence, you will have a flare, and this may not be good scenario in that regards. Treatment will result in reduction in breast development, reduction in bone age acceleration and menarche, but you may have progression of pubarchy, which is not to be worried about in this scenario. Now, you can also use medroxyprogesterone acetate, which is basically an agent predominantly only working at the level of uterus. It is not going to have any effect on growth. So it should be used only where you don't worry about growth, like intellectually compromised children who have precocious puberty, in which the scenario is there. So our therapeutic section will give you a lot of information about these parameters, including what is the dose, what are the effect, interactions. So you have got a single scenario where you can understand about these parameters as well. What about boys? So you can come quickly on the boys.
Like in girls, where during assessment of puberty status, we look at the telarchy, pubarchy, as well as the status of menarche. Two important parameters to look for in boys are the pubarchy and testicular volume, because the stretch penile length has significant subjective errors. So, pubarchy or an increase in testicular volume before 9 years is defined as precocious puberty in boys. An increase in the testicular volume suggests a central cause of precocious puberty, whereas small testes with features of precocious puberty suggests a peripheral cause. An intermediate an intermediate increase in testicular size suggests an HCG secreting tumor, which may be responsible for features of precocious puberty, whereas a differential increase in size points towards a testicular tumor.
So we have a 4-year-old boy with puberty and the testicular volumes are big. It's like 12 ml. So what do you think here?
This looks like a central cause of puberty. So one needs to look at the LH levels here.
So most important investigation is LH. If the LH is more than 0.2, it suggests central. Less than 0.1 is peripheral. Otherwise, you will generalize test. Now you find that the LH level is high. So this is central. Now you will start with GnRH analog. Anything else you want to do?
Yes, one needs to look for the cause of why this child developed precocious puberty so early in life.
So you have to do an MRI, which showed this. What is this?
This is a hypothalamic hamartoma, and it is usually associated with such high LH levels at.
So very early onset with very high LH levels. Think of hypothalamic hamartoma, which is a migrational defect. It is a normal tissue in the abnormal location. It's not a malignancy. It's not a tumor. It's just a migrational issue. So these GnRH neurons are not under the inhibitory controls of the various other neurons, and that's why they trigger precocious puberty in this regard. So hematoma is there. If you look at this case scenario, you will get that this is mostly a central precocious puberty based upon our application. 7-year-old boy with early puberty. Now here the difference is test volume seems to be less. So again, you will go for LH levels.
Yes.
And if you go by the clinical diagnosis, it will give you peripheral precocious puberty. But let's go to the investigation. The LH is low. Testo is very high. So what are you thinking of?
Again, here, because the LH, FSH are low, either it is and the testicular size is low. So one needs to think of an adrenal etiology for this precocious puberty.
So this level of testosterone elevation is usually because of CAH, rarely because of adrenal carcinoma. These are the two things I like to really think about. So you found we got an imaging done, and remember, ultrasound may not be a good etiology, good test to really pick up the carcinoma. So here what we found was that there was a enlargement of adrenals. The 17-OHP was hugely elevated. So this is a 21 hydroxylase deficiency. You start them on treatment. What is your worry in terms of what will happen to their course and height?
As soon as we start treatment, the testosterone levels go down, and this triggers the LH-FSH levels, and the child enters the secondary triggered central precocious puberty.
So at an advanced bone age, once you treat, be ready for testicular volume to go up, and you will expect to give a GnRH analog as well in this scenario. Now, what about delayed puberty? Delayed puberty basically is a scenario. So how do you go forward in terms of girls? How do you define delayed puberty, Dhoni?
So no telarchy by 13 years, no menarche by within 5 years of telarchy, or no menarche by 15 years of age is what we define as delayed puberty in girls. Again, based on the telarchy and pubarchy staging, if we have no telarchy and only pubarchy, one needs to think of a GnRH deficiency in this scenario. If there is no telarchy, no pubarchy, then one needs to think of CDGP or a systemic illness responsible for delayed puberty. In the setting of thelarchy with no pubarchy, one needs to keep in mind androgen insensitivity syndrome. And if both these are present, thelarchy as well as pubarchy, but the child has not attained, if it's a amenorrhea, primary amenorrhea, then one needs to consider Mullerian malformation or vaginal septum in this setting. So, workup of a child, a girl with delayed puberty, the first step involves screening investigation. That is, you rule out systemic illness, a thyroid disease, or prolactin. Usually, hyperprolactinemia is associated with secondary amenorrhea. However, in certain number of cases, it may be present as the primary etiology responsible for delayed puberty in girls. When the screening investigations are normal, you go to the gonadotropin levels. If they are high, a high gonadotropin level suggests an ovarian failure. So go for karyotype. If the karyotype is suggestive of Turner, then that is how you proceed. In the setting of a normal karyotype with high gonadotropin levels, go for genetic workup for primary ovarian failure, or look for other causes of primary ovarian failure, that is like pseudo hypoparathyroidism that you may consider. If the karyotype is suggestive of 46XY, you will again have to look for steroid metabolites and genetic workup in that scenario. If the gonadotropin levels are low, then you may go for a GnRH agonist test or an MRI to look for a central etiology of for the same.
You have a 16-year-old girl with delayed puberty, no breast, no pubic hair, and the height is low. So she's short, and the weight is 28 kgs. What do you get the information from this? You have got a short girl where no height, no pubic hair, no breast.
So this is either possible in the setting of 16 years. So definitely we will not be considering something like CDGP here. Low height and weight also again on the lower side, no development, looks more like an NPHD kind of girl.
NPHD slash
systemic illness.
That will be the two strong possibilities here. These steroidogenic defects are the other ones which will cause basically a problem in terms of pubarchy and breast development, but the height would not usually be so compromised. So LH and FSH are very, very low. So we would now like to do a MRI in this case, as you said in your protocol.
No, if there are no other features of
there is hypogonadotropic hypogonadism.
Hypogonadotropic hypogonadism may be isolated.
Okay.
In
so what is causing this hypogonadotropic hypogonadism? Is
yes,
it alone good enough to explain this height of 135? You have to look at something else as well. So if you look at these parameters and we input on that, now there are so many other possibilities. So this will probably give you a more generic talk about delayed puberty. You have to work up, but the first thing it will say you have to work up for a common causes. So CBC, thyroid, prolactin, and TTG. So this is a very, very short girl. She has anemia and she has clubbing. So TTG becomes important. So as you said, if you have very short girl with no pubic hair, no breast development, think of a possibility of systemic illness, and celiac will be important. So 12-year-old girl with growth failure, she's short and lean. And you got this picture. So what do you think?
So short girl with some webbing of neck, increased carrying angle, looks like Turner syndrome. But yes, again,
so P1,
again commensurate with Turner syndrome.
She has bradycardia. FSH is high and she was advised growth hormone. Do you agree or you want to do something else?
While this is a classical picture of Turner, one has to get karyotype done to confirm the diagnosis, to look for Y mosaicism in this scenario before going ahead with growth hormone or any other therapy.
So very important is don't miss a karyotype abnormality, because if you have a Y cell line, there will be a risk of ovarian carcinoma, gonadoblastoma may happen. So this girl later on presented with abdominal lump and then it was found to be a Y line. So always go for karyotype. You should not miss on karyotype. 15-year-old girl with primary amenorrhea, height is 132, webbing of neck is there, FSH is 120, karyotype is X, estradiol 20 microgram per day was started. Do you agree with this?
No. For induction of puberty, we start with 1/10 of the 10% of the adult pubertal dose. So if we go by an interpreter, it will guide us to the dose of estrogen that should be started, the preparation that should be that is preferable.
So generally we will prefer usually a 17 beta estradiol and you will start at around 10%. It will be like 0.25 milligram of estradiol valerate, and then you can gradually build it up over 2 to 2.5 years. Don't do too rapid one, otherwise they will have an issue in terms of breast development, compromise uterine size, compromise height, everything will be compromised. 13-year-old girl with Turner syndrome diagnosed at 7 years of age has been treated adequately. The parents are very concerned about whether they can do some form of fertility preservation. So what do you advise?
So the next step here is to look at the ovarian reserve, which is guided by the AMH values. So the app also does the same. It will ask you the age, the AMH levels, and based on the AMH levels. So this girl had a good ovarian reserve, and it advised ovarian cryopreservation, which is the step to go forward.
So basically, you can then get to know how you want to evaluate in that scenario. 16-year-old girl with primary amenorrhea, breast stage 4, pubic hair 1, no period. What are your thoughts here?
Primary amenorrhea with again, this girl is tall for age, so this is a very characteristic thing that should prompt towards thinking in terms of androgen insensitivity syndrome in this setting. And
so clearly, this is a scenario where you think of there is estrogen which is there, but there is no androgen which is there. But this estrogen is not causing bleeding because there is no uterus. So it's basically a XY individual who has a lot of testosterone which is not working. So no hair growth at all, no acne. And the estrogen is produced a lot, so that is causing your breast development. But because there is no uterus, there will be amenorrhea. So this is a classical scenario. And if you look at this B4 with P1 with no menarche, you will get a diagnosis of primary amenorrhea due to a complete androgen insensitivity. So delayed puberty in boys, how do you define that, Mani?
Delayed puberty in boys is defined by no testicular enlargement by 14 years of age. A stalled development wherein development started but did not progress or regressed. There is no role of defining pubic hair distribution or penile length in defining delayed puberty in boys. Similar to approach to delayed puberty in girls, the first step would always be to rule out a systemic illness in form of CBC, SGPT levels, serum creatinine, thyroid profile, and PTG levels. Micropenis, undescended testes, anosmia, synkinesia, or presence of CNS features go in favor of a more pathological sinister cause or a permanent cause of delayed puberty. The next step would be to look at the gonadotropin levels. High gonadotropin levels would again suggest a gonadal failure-like situation as we have previously seen in girls. So in the setting of high gonadotropin levels, look at the testosterone levels. Low testosterone levels will suggest something like Klinefelter syndrome, and karyotype will give you the answer to that. High gonadotropin levels and high testosterone levels will prompt you to look at the DHT. Although these children will also, along with delayed puberty, may also have some degree of genital ambiguity that may be present. So high LH, high testo, high DHT will give you AIS-like picture, whereas high testo and low DHT will give you a 5-alpha reductase 2 defect. If the gonadotropin levels are low, you look at the testicular volume. If the testicular volume is less than 1 ml, look at the inhibin B levels. Levels less than 50 suggest a permanent cause. 50 to 100, you go for a GnRH stimulated LH levels. If the levels are stimulated, then it is more likely to be transient. Whereas if there is no increase in LH levels, then it is more likely to be a permanent cause. With testicular volume above 1 ml and inhibin levels, if they are normal, you go for, it is definitely CDGP. Whereas testicular volume more than 1 ml and inhibin less than 100, again go for stimulated levels. If there is a response, then it is more likely to be a transient cause, whereas no response to stimulated levels will point towards a permanent cause.
So the major role here is to really differentiate between CDGP and pathological causes. So if you have a short child with no pubic hair development, family history, no micropenis, no neurological features, think of CDGP. But if your testicular volume is very, very small and gonadotropin levels are low, go for inhibin B, which will give you help in terms of classification from that perspective in that regards. If you have a 16-year-old boy with pubertal concern and you find onset was 13 years and stopped for the last 2 years, testicular volume is 3 ml, it's very, very soft. Height is 170 centimeters. diagnosed as CDGP. Now, do you agree with this diagnosis?
There are multiple issues in this that clearly point against. One is that puberty had started. The second is a testicular volume of 3 ml, pubic hair stage 3, and a height that is not compromised. So,
he is not short. He has got a stalled puberty, which is
Yes.
very, very important, and already has a pubic hair. So this cannot be CDGP. I think that's very important. So let's see. So as I said, these things are already not there. So you start thinking of something else and you find a big tumor. So this is something you need to be very worried about, that if you have somebody with delayed puberty, they may have a large craniopharyngioma. And this individual actually comes to us now also after around 15 years of treatment. I think he came recently, and there are a lot of other issues which are there in these scenarios to follow up. 17-year-old boy with pubertal concerns, onset at 12 years, now stopped for the last 3 years. So this is again not CDGP. Testis is 2 ml firm and gynecomastia. Now, how did this case different from the previous case?
do we also have the anthropometry?
Height is 182.
So this is a tall boy with stalled puberty, and unlike the previous case where the testicular volume was slightly more, had a softer consistency, another important thing here is the gynecomastia, which points towards an LH excess kind of situation
So
in a
like a
boy.
hypergonadotropic hypogonadism, and the most common cause of stalled puberty with hypergonadotropic hypogonadism is Klinefelter syndrome. So clearly in this scenario, your LH and FSH were high, testo was low, karyotype was suggestive of Klinefelter syndrome, again, which gives you a diagnosis. So we have developed a puberty interpreter, which really based upon key clinical parameters, both for boys and girls, will be able to give you a right diagnosis with a high level of accuracy. So all you need to do is to basically fill in a few details and you will get the answer directly from that regards. Before we close puberty, we'll have a touch base on DSD quickly. So DSD could be because of XX DSD, which is basically a scenario of acts of commission in which you have got more androgens which are there. In this scenario, you will have Mullerian structure, but you will not have any gonads. XXDSD can be because of androgen excess coming from the adrenal. The most common cause will be congenital adrenal hyperplasia, and you may also have really ovarian etiology because of aromatase. Rarely you can have gonadal dysgenesis. You can have a XY-DSD, which is basically an act of omission in which either you have no gonads, you have got no testis, you have no testosterone, you have got no testosterone receptor, and that will cause a XY dysgenesis. In this scenario, you will have gonads, but you will not have Mullerian structure. So you will have dysgenesis of the gonad which are there, or you may have an impaired DHT response because of a number of steroidogenic defects. XY-DSD is much more complicated as compared to XX-DSD. And then you can have a combination of over-testicular DSD in which you will have both gonads and Mullerian structures together. The questions are, is it DSD? How do you classify and what's the cause in that perspective? So just look at two things. Gonads and Mullerian structure. If you have only Mullerian structures, no gonads, this is XX-DSD. If you have got gonads and no Mullerian structure, it means gonad is working. This is XY-DSD. If you have got both, it means a over-testicular or really a AMH resistant state. If you have got nothing, which means that there is either an intra-abdominal testis or the testis was damaged at some point of time, but they did produce AMH, which caused regression of the Mullerian structure in that regard. So approach is look at palpable gonads. If the palpable gonads are not there, look at Mullerian structure which are present. It's most likely a XX-DSD. Look at 17-OHP levels. If it's high, it's CAH. If it's normal, it's more likely to be aromatase or dysgenesis. If your palpable gonads are present and Mullerian structures are also present, then this is complicated. This could be gonadal dysgenesis or this could be anorchia. While if the levels of AMH are high, this is AMH resistance. If you have a scenario of palpable gonads being present and Mullerian structures basically are absent either way, in that scenario, you start doing a testosterone levels. If testosterone is low, look at salt status, which will classify into salt wasting forms, which is side chain cleavage 3-beta-HSD or hypertensive variants like 17-hydroxylase deficiency, a normal salt status like LHCG receptor defect or 17-beta-HSD, and finally a high level where DHT will classify into 5-alpha reductase and AIS. the evaluation of XY DSD is often very complicated, and now we do have more of genetic tools. So the basic crux is to look at the testis and the Mullerian structure. Mullerian structure without testis, this is XX, 90%, 21 hydroxylase deficiency, get a 17 OHP. If normal, think of other things like aromatase or 11. Mullerian structure absent, gonads there or not, doesn't matter. This is XY DSD. Look at testo, low testo, look at sodium potassium. You will get a hypertensive variant 17 hydroxylase, a hypotensive variant 3 beta or side chain cleavage, or if it's normal, this is most likely 17 beta HSD or LHCG receptor defect. High testo, it's either a problem of 5 alpha or resistance action. And finally, if both are present, go for AMH in that regard. So we now have a day 3 child, who has Prader stage 4 with no gonads. So what's your next step?
Yes, so this looks like an XX DSD, no palpable gonads, uterus is present. With such degree of virilization, one needs to look at 17 OHP levels and rule out CA.
So we have developed a DSD interpreter based upon your primary inputs of gonad and neural structure. It will basically ask a 17 OHP level, which in this case was found to be very, very high. And there was also hyponatremia as well as hyperkalemia. So what are we getting out here? That this is a 21 hydroxylase deficiency. So this was a classical case. Now this is a day 3 child with DSD, Prader stage 4, no gonads again present. Now what are you thinking here?
So again, we need to look at whether Mullerian structures were present or not to basically.
So uterus is present. So this was labeled as 46 XX. So again, in this case, 17 OHP is marginally elevated. Do you think this is CAH?
No, sir. With CAH, 17 OHP levels are much higher. One needs to look at the history of maternal virilization, look at the salt status in this child. That will probably help guide.
So this child, as you said, has no palpable gonad Mullerian structure is there. There is maternal virilization which is present. 17 OHP is marginal. Sodium potassium is normal. So this is unlikely to be CAH. Think of aromatase deficiency. So this DSD interpreter is really one of the evolved, I would say, algorithm which really goes deep in terms of diagnosis and will help everybody across the thing to go at the right diagnosis in that scenario. So this was aromatase deficiency. Day 14 child with DSD who has got bilateral gonads but no uterus. So this is X1. How will you go further?
So in this setting, the next thing to look at is the salt status and the testosterone DHT levels.
So in this case, you would say that, as you said, we look at sodium. Sodium here is basically on the lower side. There is hyponatremia. There is hyperkalemia. So what do you think are we dealing with?
Yeah, so one of the salt wasting varieties may be something like based on testo levels. So testo is not so low, so more like 3 beta HSD.
So this is classically 3 beta HSD. So we can actually classify based upon these parameters as to what we are looking at. So testo was high, not low at least. There was hyponatremia, hyperkalemia. This was a 3 beta HSD. Day 14 child, again, now what's typical that you get on the image here?
What we see here is an asymmetric genitalia. So one side looks like scrotum, the other side appears more like a labia.
And, there was uterus on one side, testis on the other. So this is more likely a complicated picture. So we are saying both are present and you have asymmetrical genitalia. You're basically dealing with most likely a over-testicular DSD as a possibility. So again, the applications will help you out in that regard. So thanks a lot, Dhani, for this part. As far as puberty is concerned, we'll see if there are particular questions which are there. So we have got a few questions which have piled up in the last time. In the potassium less than 3.3, potassium you added is 20, but 3.3 to 6 you add 40. So I think this is again a confusion. So when we say a normal potassium, you do not add potassium in the hydration phase. It's the first 10 ml per kg. There you don't add. You add from the second phase. While if the potassium is less than 3.3, you immediately add the first bolus you are giving, you add potassium there. What time frame can be objectively termed rapid progression of pubertal signs? Good. So generally, I would say anybody below 6 years of age thinks of progressive puberty. Anybody who between 6 to 8 with B3 and above is progressive. Otherwise, wait for around 6 months to get a good answer to that. We also add to that the bone age. So if your height SDS for bone age is below -2 and the uterine size, if uterus is more than 34 mm, if your endometrial thickness is about 2 mm, we start thinking that there is something wrong. Is it common for prolactin to be high in CPP versus peripheral? We do not give any importance to prolactin in central precocity, Dr. Randa, because it is not really much significant. It's not going to do much role. So we don't do prolactin there. Dr. Elizabeth is asking, how do we treat aromatase deficiency? Very, very interesting question. So for aromatase deficiency, we have to replace estrogen. Now, what we do is that we start off with a low estrogen and then build it up like a pubertal development. The problem is that often the ovaries would fail by the time they come to us because there will be a lot of other issues which are there, because estrogen is essential in the ovaries to prevent the oocytes from masculinizing. So this becomes important from that regard. So we have covered 3 big topics. We will now move forward to the 4th part, which will basically be about the thyroid disorder. So I'll touch base a bit about physiology, and then Vibha will carry about the overall approach from that regards. So thyroid disorders, we know that as we talked about the HPG axis, we got the HPT axis, in which TRH produced by the hypothalamus causes the production of TSH, which acts on its receptor to produce T4, which is then peripherally activated into T3 via MDI1, and it is inactivated via MDI2. Now, T4 and T3 do not circulate in the circulation. They usually circulate bound, and only a small fraction of it will be actually the free form. And when we are assessing these parameters, the free form become important because they are the ones which are going to be metabolically active in that perspective. And then we have got the thyroid receptor. So in primary hypothyroidism, the first thing which should happen is a rise in TSH level, followed by a decrease in T4. Body will do everything to preserve T3. So T3 levels are the least important indicator, the insensitive indicators as far as the primary hypothyroidism is concerned. The most important is the T4 levels which are there to look at in this perspective. For central hypothyroidism, however, your TSH will not rise because your problem there, but TSH may go high because of a bioinactive TSH. So a normal TSH with a low T4 becomes significant. And then in thyrotoxicosis, of course, the most important is TSH, which will go down first, followed by you will have increase in T4. And then in iodine deficient area, particularly, you may have T3 toxicosis, which is there in this perspective, which becomes important in that regards. Now, when you are assessing the thyroid functions, always look at the TSH levels. And we know there is a rapid surge which happens in the first week, followed by a decline which happens. So whenever you want to do a thyroid screening in the newborn period, always do it after 72 hours. That becomes important in that regards. Cord blood is something which can be a compromise. Otherwise, day 3 becomes important. If you're doing it before that, you need to use a higher cutoff in that regards. So in the first week, levels above 40, between 1 to 2 levels about 20, and beyond that level about 10 require action, and 20, 10 and 10 for first week, second week, and then beyond would be significant in terms of follow-up which is required. In children, we tend to have a higher cutoff in terms of the cutoff for TSH and management compared to adults. So now which test to order and how to interpret? So remember, TSH basically has a significant diurnal variation, but that's not significant enough to affect your interpretation. So you can do TSH any time of the day. So if you have a child who has come to you from 200 kilometers or something, don't ask them to come the next day to get the TSH in the morning. Get it the TSH done right away. T4 is of course affected by TBG, so FT4 becomes more important. T3 is affected by monodiiodinase, so it is a useless investigation for primary hypothyroidism. It's a good test from a more of a thyrotoxicosis perspective. So in hypothyroidism, the first thing to happen should be a high TSH with a low T4, and T3 will be the last to fall. So in this scenario, what you need to do is that you do a T4 and TSH, do not do a T3. While in the scenario of excess, you will have TSH fall, T4 rise, and you may have disproportionate T3 rise, as I said in iodine deficiency, which is T3 toxicosis. And in this scenario, you need to do all 3 investigations in that regard. So whenever you are interpreting thyroid functions, do both FT4 and TSH. If your FT4 is low, your TSH should be sky high. If it's more than 20, it is definitely a primary hypothyroidism. If, however, the level is below 20, you start thinking that this could be something else like central hypothyroidism. If FT4 is high and TSH is low, this is classically a thyrotoxicosis. While if your FT4 and TSH both are high or detectable, you start thinking of a rare cause like TSH adenoma or a thyroid hormone resistance in that regard. So we've developed a thyroid interpreter, which provides you age-specific guidelines for evaluation in 4 different categories: the neonates, children, non-pregnant adults, and pregnant adults in that regard. So now we'll hand over to Vibha to carry on from that perspective of thyroid disorder.
So we all know neonatal screening is very important and it should be done at day 3 of life. Generally, the whole serum levels are twice the level of TSH present in blood levels. So when we have TSH of more than 40, we should go for the free T4 level, and definitely we should start the treatment immediately. But when we have TSH of less than 20, and if it is a 34, if it is taken between the 24 to 48 hours, generally no treatment is required in 99.9% cases. But if we have the TSH between 20 to 40, then we should repeat TSH after 14 days. And if after 14 days, the TSH still greater than 20, then get the free T4 done and start the treatment. And when after 14 days, the TSH level goes down, it becomes less than 10, then generally no treatment is required. And if we are in the midway scenario, like between 10 to 20 TSH, we should repeat it after 21 days. And if it is more than 20, start the treatment. And if it is between 6 to 20, we should go for the free T4, get the scan done, and we can start the treatment immediately or can wait. But definitely we should start the treatment in these scenarios. But when the TSH is less than 6, no treatment is required. In the scenarios, we should go for the repeat screening after 2 weeks. They are the prematurity, the children with trisomy 21, the same-sex twin, and the children who require hospitalization. So if after the evaluation of the TSH, the next step is to look for the presence of thyroid, whether it is present or not. Then the thyroid scan becomes important. And if the thyroid is not in the position, it is ectopic. And if there is an increased uptake in the thyroid scan, it could be due to dysharmoniogenesis or iron deficiency. But if there is no thyroid uptake visible in the scan, then go for the thyroid ultrasound immediately, because it could be absent due to agenesis, but the thyroid could be present and it is absent in the scan because of the presence of TRAB antibodies. And if the TRAB antibodies are present, then look for the TRAB antibodies in the mothers also, because they are transferred for the mother. And if the TRAB antibody is negative, then the sodium iodide importer defect or the TSH receptor defect could be the possibility. So when we start the treatment in congenital hypothyroidism, we should always start early and with the higher doses. But the value of free T4 plays an important role. And if the free T4 is less than 0.4, then start with higher dose of 12.5 to 15. And if it is between 0.4 to 0.8, you can start with a little bit lower dose of 10 to 12.5. And if it is greater than 0.8, start with 8 to 10 microgram. We have to keep the free T4 in the high upper limit, and we reduce the dose when the free T4, if the free T4 is going very high, and sometimes at the age of 3 years, we can stop the treatment where the dose requirement is very low, like 2.5 microgram per kg per day. So for the titration, we start monitoring when we start the treatment, get the second level done after 2 weeks, and then 4 weeks. And for the dose adjustment, repeat the thyroid profile every 6 weekly. Our target has to keep the free T4 level in the upper limit and the TSH between the level of 0.5 to 2. So if we have high TSH and low free T4 in our report, definitely we need to increase the dose in this setting. And even if the TSH is high and FT4 has come normal or it is high, then we have to continue the dose. We should not target the TSH. In congenital hypothyroidism, we have to target the free T4 value. And if the TSH level and the free T4 level comes in the normal range, continue the same dose And even if the TSH is normal and free T4 is in the higher level, we should continue with the same dose. And if TSH is low and FT4 is higher, then in this scenario, we have to reduce the dose of thyroxine.
So now we'll discuss about a few cases, and you talked about how timing becomes very important. You got a day 4 child with TSH of 22. Now, as said, what will you do at day 4, 22? You will like to?
We have to repeat the sample after.
So on day 13, it was 18. So what should you do here?
So it is again between, it is less than 20. So we need not to.
So if you go back to our interpreter, it says borderline abnormal feeling, repeat TSH after 2 weeks. So again, we have to repeat this. So this was done a bit prematurely. Now at day 21, it becomes 11.
So it is between the range of 6 to 12 where we need to go for the scan. And
yeah. So clearly, again, if you look here, it basically says consider workup and treatment. So again, this interpreter will, based upon whatever TSH value you enter, along with the age, will tell you what is the best strategy from that perspective. And this was found to be hemiangenesis. 20-year-old girl with TSH of 28. What do you think here?
So this is the sample is taken at a very early stage when there is a TSH surge. So we cannot consider this TSH to go for the treatment. We should repeat it after
2 days, or you can use a higher cut of 34. So this should have been repeated. Day 10 child with TSH more than 100 and FT4 is on the lower side. Scan shows no thyroid tissue. What is your plan here?
So we cannot consider here on the basis of the scan that there is no thyroid tissue because it could be due to the TRAB antibodies or NIS importer defect. We should go for the ultrasound from the scan and we'll see whether it is thyroid tissue.
So clearly in scenarios where you have got a classical case of primary hypothyroidism, of course you have to treat. But if you have no uptake still, you should go ahead and look at whether thyroid is identified on ultrasound or not. And in this case, ultrasound did show a utopic thyroid. So clearly in this scenario, mother had hypothyroidism. So what is the cause here?
So it is due to the presence of TRAB antibodies that has been transferred.
So transplacental passage of antibodies, which is causing this scenario. So now acquired hypothyroidism.
So in the acquired hypothyroidism in children can present with growth failure, pubertal disorders. There could be cardiomyopathy in some cases, hyponatremia, it could present like SIDH picture, myopathy, and the hyperandrogenism. They could also present with fatigability, lethargy, worsening of school performance, and emotional ability as well. So for the evaluation of primary hypothyroidism, initially we should go for the free T4 level and see whether the free T4 level is low or not. Then see what is the TSH level. And if the TSH level is above 20, then definitely this is the case of primary hypothyroidism. But if the TSH is less than 20, then we have to go for the MRI brain cortisol levels to confirm it whether this is central or not. And if the TSH level is normal, if the FT4 level is normal, then again we should go for the look for the TSH levels. And if it is below normal, if it is below 6, it is considered to be normal. And if it is more than 10, it is primary. But there are situations when the TSH is between 6 to 10, and we are in dilemma whether to treat or not. So we should look for the risk factors, that is the TPA positivity in the patient, family history in the of thyroid disorder in the family, if there is a girl child, and if the goiter is present or not. So if all these risk factors are present, then we should definitely start the treatment. And if not, then we can follow up this case. Regarding the dose initiation in these cases, we use like for the age of 1 to 3 years, we start with 4 to 6 microgram per kg per day. For the 3 to 10 years, we start with 3 to 5. And for the children more than 10 years of age, we start with a lower dose of 2 to 4 microgram per kg. In adult, there is a uniform dose of 1.6 microgram per kg per day. But we can also use 100 microgram per kg per meter square per day for initiation of the thyroxine. Initially, when there is an overt hypothyroidism, always remember to start with a lower dose, titrate slowly, because when we start with a higher dose, there is a lots of complication. The patient can develop benign intracranial hypertension, worsening in the school performance. And in the subclinical hypothyroidism, we can start with the adequate dose. And we should always keep in mind that there are lots of drugs and interference of food with the absorption of the thyroxine. So the drug like calcium, iron should not be mixed with the intake of thyroxine, and it should be taken empty stomach, and breakfast should be advised to take after 30 or 45 minutes. And the thyroid tablet should not be exposed to sunlight. So now coming to how should we titrate the dose of thyroxine, depending, we start the monitoring every 6 to 8 weekly, which is longer than the congenital hypothyroidism. And then we go for every 3 monthly monitoring, and then 6 to 12 monthly. Here our target is to keep the FT4 level between the 18 to 30 picomole per liter, and the TSH with the same range of 0.5 to 2. And if we get the report with high TSH level and low free T4 level, definitely in this case we have to increase the dose. And even if the TSH is high and FT4 is in the normal range, continue with the same dose. And if both TSH and FT4 is in the higher range, always for the adherence, always ask whether the test is done before the intake of medicine or not. And if both the T4 and TSH is within the normal limit, we can continue with the same dose. And if the TSH is low and FT4 is high, we should reduce the dose. So we have a 12-year-old boy who presented with obesity.
So now in this case, he is again reasonably tall. TSH is 7.91. We discussed this in the last discussion as well. So why do you think this child actually has a high TSH?
So definitely the child has obesity. This high TSH is due to the effect of obesity. Body wants to compensate, body want to metabolize this this fat. So the TSH has risen up. So this subclinical range of TSH is due to obesity.
So this is basically the impact of leptin at the level of TRH, which is causing the hypothalamus to produce more TRH, causing more TSH, but your T4 is normal. So this case, you don't need to treat. Get a TPO maybe. If it's negative, do not need to treat. 12-year-old girl with lethargy, height is on the lower side, and FT4 is low, and TSH is 12. So this is a primary hypothyroidism.
So definitely this FT4 is low, but we should, in the case of primary hypothyroidism, TSH value should be more than 20, and in this case it is less than 20.
Generally, if you look at it, most cases it's more than 100. So this 12 is very, very inappropriately low. So you will like to do a
MRI, pituitary, and the cortisol level.
So if you look at our interpreter, it says likely central, and you have to look at cortisol and MRI before you start treatment. So I think this is one of the most important areas we want to intervene, is the missed central hypothyroidism, which can cause significant problems. So we recently had the newborn also. In that case, though, there was no confusion, very low FT4, very low TSH. But again, normal TSH with a low FT4, get worried. There's something wrong going on in that scenario. So thyrotoxicosis is a condition which is rare, but if you have a significant weight loss, tremors, eye signs, myopathy, polyuria, think of thyrotoxicosis. Ideally, if there is clear-cut goiter, eye sign, you may avoid nuclear scan, but generally doing a scan or a TRAB antibody will help out. If scan shows increased uptake, which is localized, this is a solitary nodule. This requires surgery. This is a multiple intake. This is toxic MNG. Again, medication/surgery. If it's a diffuse intake, this is a Graves' disease. On the other hand, if you have a decreased intake, no eye signs, no goiter, there is tenderness, you can think of subacute thyroiditis as a scenario. Now, TRAB antibody is now also emerging as a good test. It will really cut down the need of having a thyroid scan in that regards. So this will give you a clue. So now we have a 12-year-old girl with tremor whose FT4 is very high, TSH is low. So this is the site of thyroid production is from the pituitary or the gland. So this is a primary, you can say, like there is a thyroid swelling, but there is no eye sign. Tremors are present. How will you go ahead?
So the picture is looking like signs of thyrotoxicosis as well as a increased sympathetic activity in the form of tremors. So we look definitely treatment should be started.
So would you like to go ahead with the scan or not in this case?
So with this high level of FT4 and low level of TSH and
there is goiter, so which you may avoid it. Now you cannot say that if somebody wants to do, they can do it, of course, they can do a TRAB antibody, but even if you don't do it, you will be getting the diagnosis. So our pathway will tell you how to really guide, start, follow up, and manage. And what are the things you will tell him once you're starting them on methimazole? What should be the thing that they should look at?
So they should be very cautious when they have fever, sore throat, because in that case,
So if they have severe sore throat
Throat
pain, they
pain,
should get a CBC done, stop the drug immediately. This mostly happens in the first 100 days of treatment. And do you think this girl is going to respond well to medical therapy, or you would need to go for radioactive iodine later? What are the chances of remission in this case?
So, first of all, the gender and the size. I don't know what is the size of the gland, but if the female gender is more likely to respond to the
But
therapy.
even after that, it's like 40 to 50%. So many may not respond. So the chances of radioactive iodine therapy is also there. Now, 10-year-old girl with thyroid nodule, and you are seeing that there is a big nodule which is there. She's clinically euthyroid, TPO negative. So you, from your side, you think this is fine? Anything else needs to be done?
No, so definitely we can see that there is asymmetrical thyroid swelling in the neck, and we cannot just reassure the child and send back. Definitely, this child requires evaluation. And for
what
this,
will be your evaluation?
So this is euthyroid. We should get the scan done. Then
scan means
this technician radioactive
in a euthyroid treatment or an ultrasound.
Ultrasound scan.
You should get an ultrasound to look at the morphology and then do the thyroid scoring and then decide. But mostly in this big size would require an FNAC. But yes, definitely we should do a ultrasound. So you need to understand that thyroid nodule is a big dangerous sign in children. 10% risk of malignancy roughly. So you have to look at the ultrasound and get an FNAC done depending upon the scenario. So we've got multiple tools for thyroid, which include the approach pathways for congenital and acquired hypothyroidism, thyrotoxicosis, nodule, and latest the thyroid interpreter, which Vibha actually had recently presented in the American Thyroid Association, which tells you the precise diagnosis based upon the entry of just FT4 and TSH across ages and gender. So this all help out in that regards. Thanks a lot, Vibha. So before we move ahead with the last part, which is the sodium disorders, we'll see if there are any further questions which have come around that. So I think it's pretty much the same. So we will try to finish off. So we are running around 5 to 10 minutes only behind time. So hopefully we should be able to catch up here in this regard. So we will touch base now about sodium disorders. We've already talked a lot about growth, glucose, puberty, and thyroid. So it's been an intensive 2 hours and 15 minutes till now. So hopefully the last over is also going to go very fine. So it will be about sodium disorders now. So when you talk about sodium, sodium is unusual in that it basically level depends on not only the sodium level, but also on the volume. So it depends upon the sodium, tonicity, and volume. Now, if you have got scenarios where your water becomes more, you will have hyponatremia. And if your water becomes less, you will have hypernatremia. So the major cause of sodium disorders is not sodium level, it is the free water level. That is something important to remember. Now, there are two ways in which your water is maintained. One is thirst. So you will drink whenever you are thirsty. And this is a major defense against hypernatremia. The other big factor is how much urine you are leaking out in that regards. And it's a defense against hyponatremia. So whenever you have too much fluid, you will lose urine. And that's why hyponatremia will not develop. On the other hand, if you have a lot of dehydration, you will drink. So the main work of thirst is to prevent hypernatremia. The main work of renal regulation is to prevent hyponatremia. But abnormalities there could be a problem. The other thing to remember is that problem in one mechanism may be compensated by the other. So if you're not drinking, your urine output may become less. If you're having too much urine output because of DI, you may drink more. So if you have a normal thirst or a normal urine output, you will usually not have a problem. So one of them needs to be normal. If both of them are gone, then you will develop a lot of problems of hypernatremia or hyponatremia. Now, if your tonicity increases, then body wants to drink more water and to prevent and would like to have more loss as far as the free water is concerned. So you will have the secretion of AVP, which will go into the kidneys and work via the V2 receptor aquaporin channel to cause increased urinary concentration. So concentrated blood, concentrated urine. This is your normal response in this scenario. Now, if you have, on the other hand, problems in terms of volume, when your volume comes down, You will have the second system which comes into the picture, which is the renin, angiotensin, aldosterone system, which will basically go ahead and conserve, increase your volume. It will decrease the loss of sodium and decrease the loss of water while increasing the potassium loss. So RAS compensatory mechanism is expected to have a hypokalemia in that perspective. There's another player if you have too much volume, which is the atrial natriuretic peptide, which is going to act in a system to cause loss of sodium. It is also going to inhibit your aldosterone secretion also in that perspective. Now, why are we bothered about hyponatremia? Sodium is the major osmol which is there in the body, and it's the major regulator of osmolality. If you have hyponatremia, your cells will become swollen because the fluid goes inside. And in this scenario, if it's very acute, you may actually have coma, seizure, and distress. If it's acute moderate, you may just have some nausea, confusion, and a headache. If you have acute severe, this is an emergency, requires immediate treatment in that regards. While if it's chronic, the body will develop osmoles which will go out of the cell and cell will become a normal volume. And this will be an adaptive state. In this case, you will have weakness, cognitive defect, and instability. And very importantly is the rate of change, which is more important. So people say whether I worry about a sodium of 122. So this sodium of 122 has no meaning to me. If somebody is having the sodium for the last 2 weeks, there's nothing to worry because they might have compensated. But if you know that yesterday it was 135 and now it's 122, this is an acute hyponatremia, which is a major cause of worry and concern in that scenario. So once you correct, and if you are doing too much of correction, your osmoles are already there, and in this scenario, you may shrink. So this will cause what is known as osmotic disequilibrium syndrome, which is a very dangerous scenario, happens a few days after the correction, and you can have significant problems in that regard. So you need to be bothered about this in that perspective, and you need to worry about that in that regards. And this is something you want to do. So what you want to do is that if you have hyponatremia, do a gradual correction. Do not rush in terms of correction in that perspective, and problems may happen. So hyponatremia can be a problem of too much free water like cardiac failure, liver disease, or nephrotic syndrome, or SIADH, which actually is considered a euvolemic form, but in true nature, it's actually a hypervolemic form. In SIADH, what happens, your fluid becomes more, ANP comes into the system, and that causes loss of sodium. Now, if you give more sodium, this ANP will knock the sodium off. So giving saline is not going to help out in this perspective. Very importantly, SIADH is a diagnosis of exclusion. You have to exclude cortisol deficiency and hypothyroidism before you label somebody as SIADH. On the other hand, you have got a sodium problem, which is rarer, but it will be more dramatic. So you may have a problem of RAS defect, which will cause hyponatremia with hyperkalemia, and tubulopathy and diuretic, which will cause hyponatremia and hypokalemia. So always look at sodium and potassium. If sodium goes up, potassium should go down. Sodium goes down, potassium should go up. Both are going down, you're dealing with a tubulopathy or a gastrointestinal loss or a diuretic use. Both are going up. Only rare scenario is Gordon syndrome, hypernatremia with hyperkalemia, which will be there in this scenario. So we'll now start with hyponatremia, and Dhwani, can you please come up and talk about hyponatremia a bit?
Thank you, sir. After understanding the etiology, it will be very easy to understand the approach to hyponatremia. So as we know, there can be principally two causes of hyponatremia, either an excess free water or a solute loss that is happening. In the setting of an excess free water, one needs to, the patients usually have a U or hypovolemic status with low uric acid levels. And in the setting of sodium loss, which is the other scenario, a patient is more likely to be hypovolemic with high uric acid levels due to dehydration. In a child with excess free water, it could be either because of an overload secondary to cardiac, liver, or renal failure, wherein the urine sodium concentration will be low because low plasma osmolality with low urine osmolality will be the picture here. Excess free water with a reduced loss are conditions like SIADH, cortisol deficiency, and hypothyroidism. Here you will have low plasma osmolality with a concentrated urine, resulting in urine sodium more than 25. Hyponatremia from sodium loss, one needs to identify whether this sodium loss is from renal source or an extrarenal source. Extrarenal causes will commonly include diarrheal losses or sweat losses, as may be seen with cystic fibrosis. Typically, urine sodium will be low here because most of it is lost in other sources. Sodium loss due to renal causes can be either a tubular, wherein comes your diuretic use, or a tubulopathy, or due to RAS defect, which may be either a combined glucocorticoid mineralocorticoid deficiency resulting in hyponatremia, or an aldosterone deficiency, or a situation of pseudohypoaldosteronism. The scenarios in between that I described have a higher urine sodium concentration. So if you look at the approach, because of dilution, uric acid levels will be low in situations of fluid overload and SIADH, whereas it will be high in conditions causing relative dehydration. Similarly, urine sodium will be low in the setting of diarrheal losses as well as in the setting of cardiac renal failure, liver failure, wherein your plasma osmolality is less and your and therefore your urine sodium will be less. In all the other scenarios, there is either a sodium loss in urine or there is concentrated urine as an SIDH. So in these settings, the urine sodium levels will be higher. If you look at the potassium levels, as we've already discussed, diarrhea and diuretic use are characteristically associated with low potassium levels, whereas a defect in the RAS axis or renal failure will give you high serum potassium levels. Finally, looking at the hematocrit, in parallel to what is seen with uric acid levels, the hematocrit levels are higher with conditions causing dehydration and lower with conditions causing an apparent fluid excess state. First step in evaluation of hyponatremia is to ascertain whether or not this is a true hyponatremia, and one needs to look at the sodium levels in the setting of concomitant sugar levels, lipid, protein, and creatinine levels. Based on the volume status, it is hypovolemia. Think of again cardiac, liver, or renal failure. In the setting of euvolemia, you're thinking in lines of SIADH, but before you reach that diagnosis, ensure a normal thyroid axis and cortisol axis. When these are normal, you make a diagnosis of SIADH. In the setting of hypovolemia, look at the urine sodium levels. If urine sodium is low, then the loss is more likely to be from an extrarenal cause like GI or cystic fibrosis. With high urine sodium loss, one needs to ascertain whether this is a concentrated urine or a sodium loss happening in the urine. So look at the potassium levels, which will guide you towards the pathology. Low potassium will guide towards a tubulopathy or diuretic use. High will guide towards a RAS action defect.
So I think the most important thing, of course, as I said, is to look at the volume. And once you know the volume, you look at the urinary sodium, and that will give you the diagnosis along with potassium. So you have a 12-year-old boy with DK, sodium is 126, blood sugar is 700. Would you like to give 3% saline to this individual?
No, sir. Again, as we've seen, to define true hyponatremia, one needs to correct it for the sugar levels. With every 100 mg per deciliter rise in the sugar levels, your serum sodium level decreases by 1.6 milliequivalents per liter. So correcting...
So we should always use the corrected sodium, which is available through these equations, which are there in that regards. You have a 1-week-old boy with hyponatremia and hypokalemia. There is no dehydration. Now, how will you proceed here?
So this basically is a setting of, and we do not have signs of dehydration.
Yeah.
Yes. So normal, a low sodium with normal potassium in a euvolemic child, one needs to look at cortisol and T4 axis.
Yeah.
Look for features of midline defects. A micropenis in this boy will guide.
Yeah. So we have a blood sugar, so he's neither dehydrated nor overhydrated. So you look at thyroid and cortisol, which were found to be low. So this is most likely a case of MPHD, and you will get other signs like micropenis, and you may have a cleft lip, cleft palate. 3-week-old child with failure to thrive, sodium is 110. There was no gain in weight, dehydrated with PCV62. So how is it different from the last case?
Yes, so unlike the previous case, there is no documented hypoglycemia. There is a significant failure to thrive and a much lower sodium levels, suggesting that there may be multiple players at hand responsible for this hyponatremia.
The child is dehydrated as well.
Yes.
Urinary sodium is high. Potassium is very high. So which direction are we heading to?
Yes.
Hyponatremia with hyperkalemia.
So we're looking at something like a RAS defect, which is responsible for.
And so this scenario, it's typically going more towards a case of CAH being a very likely diagnosis in this scenario of hyponatremia with hyperkalemia. 14-year-old boy with drowsiness and sodium of 116, euvolemic with a high urinary sodium and a urinary osmolality, labeled as SIADH with fluid restriction, but the child became very sick with this fluid restriction. So what was wrong in this management?
As we've already discussed, SIADH is a diagnosis of exclusion. One needs to ensure a normal thyroid and cortisol axis before jumping to fluid restriction.
So definitely you have to look at thyroid and cortisol as per this approach pathway as well before you really go ahead in terms of evaluation. 6-month-old girl labeled as cystic fibrosis with failure to thrive and recurrent chest infections, high level of sweat chloride. So that's why they diagnosed cystic fibrosis. There is, however, no absorption issues, no steatorrhea. And interestingly, she came to us sick. She had hyponatremia and hyperkalemia. So do you think this is cystic fibrosis?
A very close mimic, especially in terms of clinical features with cystic fibrosis, pseudohypoaldosteronism type 1, which also presents with recurrent chest infections due to a thickened mucus, but in the absence of an exocrine pancreatic insufficiency. So with this,
high potassium will be against.
yes.
So CF usually will have hypokalemia.
Yeah.
So this is extremely unusual. So this is classical, as we said, going more in favor of a severe form of pseudohypoaldosteronism. And in this case, you had a very high aldosterone. So this was classically a case of pseudohypoaldosteronism in that regards. 1-month-old boy with reduced feeding, birth weight was 31, not gaining much weight, hyponatremia, hyperkalemia again, 17 OHP is normal and cortisol level is high. PRA and LDO is also high. So what are you thinking here?
So again, very similar to the previous case, this child has failure to thrive and a picture similar to RAS defect with very high aldosterone level. So this suggests that there is a receptor problem or a resistance that is happening.
So there is a aldosterone resistance, most likely, but as you discussed earlier, you should always think of a obstructive uropathy before you go ahead with making a diagnosis. So there was a lot of infection there, which was a transient cause, which improved over time as well. So this was an obstruction which is there. So now in terms of treatment, thank you, Dhwani. So we have to look at two things, the duration of treatment and the symptom. So the duration is less than 48 hours, which means acute hyponatremia. And there are severe symptoms that we discussed. That means coma or seizures. You are then justified to use 3% saline, and that also only to increase the level slowly. So 3 to 5 ml per kg of 3% saline, and then you rise 9 to 12 millimoles per liter per day. If on the other hand, you have a mild to moderate, that is confusion and headache, in that scenario, you give 1 to 2 ml per kg of 3% saline, you build up around 6 to 9 millimoles per liter per day over the time. If the duration is more than 48 hours, that is chronic, or you don't know. In most cases, you don't know. You assume it to be chronic because you don't want to err in the side of error. So here, if there are severe symptoms, you may give some 3% saline, but again, the rise should be very low, below 6 millimoles per kg per day. And if it's mild to moderate, that is less than 120 with nausea, no need of 3% saline. We have burnt our hands with a lot of cases managed with very high levels of 3% saline, and they will develop 2-3 days later, they will improve, and then they may develop some chorioathetoid movement, some stiffness in the body, a straight stare, vacant stare, and this could be osmotic disequilibrium syndrome, very difficult to manage. But if you are overcorrecting sodium, the option is you give them more free water. You give them AVP, which will bring back their sodium to back, which is the relowering, which may be required in that setting. Now, one of the most common challenges in management is hyponatremic dehydration, where you have to look at multiple factors. How much is your fluid deficit, which is basically based upon your dehydration level, and 0.6 is the effective body water. Then how much of this is actually a hyponatremic sodium deficit, in which you basically calculate based upon EBW and the sodium deficit. Then you go ahead in terms of fluid deficit. Then you talk about maintenance for 48 hours. We talk about 4-1 or 150-20, whichever rule you want to use, and give sodium 2 to 4 millimoles per kg. You give a correction of how much bolus has already been given in terms of fluid and sodium. And finally, you decide how much fluid volume and tonicity is required. So this is a very complicated formula, which often people get confused. So what we have done in this scenario is basically to develop a calculator which based upon the inputs will give you how much fluid rate is required, whether you want to give 0.9 saline or 3% saline. Remember, whatever fluid you calculate, there will be a problem. So if there is a rapid rise, you have to be ready with 10% dextrose, which is there. You should be ready with vasopressin to bring it down back in that regards. Now, hypernatremia is a different ball game. So hyponatremia is because of more free water. Hypernatremia is largely because of less free water. There is hardly any cause unless you're giving too much sodium and the kidneys are overwhelmed to cause hypernatremia because of load. So it's usually free water loss, which is associated with dehydration, and sodium gain, which will cause fluid overload. So if somebody is not taking enough water, there's a lot of urinary loss like diarrhea or sweating, or there is an AVP problem in DI and you are not drinking. Anybody with DI, as I said, will not develop dehydration and hypernatremia, but they will develop if somebody is not getting access to fluids. In infants, post surgery, you will develop these problems. If the RAS axis, on the other hand, is high or there is a sodium load, you may have a problem. Similarly, if you have osmotic diuresis, you may also be loading a lot of fluid like mannitol, diabetes, there will be hypernatremia. So often in DKA management, both hyperglycemia and mannitol contribute to hypernatremia. And everybody gets too much worried about sodium. Do not get worried about sodium in DKA, get worried about potassium. Get worried about phosphorus. That is more important. Sodium is expected to go high. If it's going low, I will be more worried in that scenario. So what hypernatremia does is that it brings fluid outside the cell, which will then shrink. So you will have acute symptoms like altered sensorium, seizures, and hemorrhage. Body will try to compensate by developing osmoles inside the cell, and it will compensate. You will have chronic symptoms like fever, more of dehydration, failure to thrive. But once you correct rapidly, fluid will go in and this will cause cerebral edema. So in hyponatremia, you have got acute state cerebral edema. Treatment, you will cause shrinkage. In hypernatremia, you have shrinkage. Treatment will cause a cerebral edema, which will happen in that perspective. So now we'll have Alappan who will talk a bit about hypernatremia.
So as Sarah has already described the etiology of hypernatremia, there are two different ball games. Number one is the free water and the second one is the sodium. So if there is reduced free water, there could be two possibilities. It could be reduced intake like in neonates or in adiposic syndromes, or there could be increased chance of increased free water loss as it could be of two types. It could be of extrarenal, where like in the setting of the diarrhea, vomiting, where usually the urinary sodium level is less than 25 and it associated with dehydration. And at the same time, there are some renal causes of increased free water loss, like in diabetes insipidus and osmotic diuresis. So there could be hypernatremia due to sodium load, and the main and the pathology of hyperaldosteronism doesn't cause much hypernatremia. Rather, it presents like hypertension and hypokalemic alkalosis. And there could be a excess sodium load and excess sodium load from the outside, which may also contribute to the hypernatremia. In this setting, urinary sodium is usually more than 25, and it is usually associated with fluid overload like situation. So we approach the hypernatremia, we have to initially rule out whether there is any history of any salt excess, like in improper preparation of ORS, any supplementation of mannitol, and if there is blood sugar level is high or not. After excluding all these things, we have to look out for the urine osmolarity. And if Sarah has already described, concentrated blood should have a concentrated urine. If urine osmolarity in a concentrated blood is less, there we have to think about the possibilities of diabetes insipidus, and one must look for the AVP response to rule out whether it is a central DI or a nephrogenic one. A central DI usually have a response of more than 50% rise in the level of AVP after rise of osmolarity after using AVP. And if urinary osmolarity is more than 600, or urine is more like concentrated, then we could have two possibilities, whether the urine sodium is less than 25 or more than 25. If it is urine sodium is less, it is most likely features of GI loss like in diarrhea and vomiting, or if it is more most likely a case of salt load or sodium load from the outside.
We have a 14-day-old girl. So you already talked about again that urinary sodium and urinary osmolality with specific gravity is going to be helpful. In scenarios where osmolality is not readily available, you can use specific gravity also. Specific gravity less than 1005 typically is like 300, 1010 is like 600. So don't get worried about that. 14-year-old girl with failure to thrive who is not lost a lot of weight now, not regained the weight, she's exclusively breastfed. Sodium is 182. What is the cause here?
Yes, so this is the 14-year-old girl who had presented with failure to thrive. He is a breastfed child and a sodium of high 182 level. I would like to know whether the breastfeeding is adequate in this kind of setting.
So this is a classical presentation of what we say quote unquote breast milk related hypernatremia, in which you have an inadequate milk production. Urinary osmolality was high, which is expected, which should have happened, and the urinary sodium is also high. So this is load, which basically means a breast milk related hyponatremia. How could you have prevented this from happening?
We could have prevented by frequent feeding in this child, and assessing the mother whether she is drinking more water, whether milk production is adequate, and the urine output in this child.
The baby is having at least 4 to 5 times urination or not, that becomes important. So if you go by our approach pathway, this will really go towards a sodium load in that perspective. And we give options for both urinary osmolality as well as specific gravity, and we go from there. 6-month-old boy with dehydration, dovey skin, sodium is 178. Now in this scenario, urinary osmolality is 800. So this is DI.
No, this is again this setup of hypernatremia, that's concentrated blood. Urine osmolality is also concentrated, so it goes against DI. Rather, we would like to see the urine sodium in this setup,
which is also high. So this is a sodium low. So how did he get? Did he eat a lot of salt?
I expect there is some pathologies going behind. So I'd like to know the history, whether any kind of diarrhea or vomiting was present.
The most common cause is that when you have an inappropriate ORS diarrhea, a lot of concentrated ORS was given, and that's why the sodium became high. Otherwise, nobody should develop hypernatremia. You will lose in the urine. So that is the mechanism. 3-month-old girl with altered sensorium. Again, this is an important message that do not do a water deprivation test in the presence of hypernatremia, because that could be dangerous, that could be lethal. So this is something which has to be avoided. 6-month-old boy with failure to thrive, there is hypernatremia. Now here what you are seeing is the urinary osmolality is low. So this is more likely towards diabetes insipidus. Insipidus, and AVP did not increase the level. So this is mostly a nephrogenic form. Now which nephrogenic form are we looking at?
So 6-month-old boy, this could be a B2 receptor.
So most likely X-linked, not V2. Oh. V2 is X-linked. Aquaporin is the autosomal recessive one. So this is most common. You will ask history for polyuria in the mother during pregnancy. You will ask history for polyuria in the maternal uncles. Antenatal hydroamnios, those things will be present. 3-year-old boy with polyuria and sodium of 154. Now what you are seeing, urinary osmolality is 180. So this is suggestive of
it goes towards the DI.
DI. Now, post AVP, it became 300. So there is a rise. So this is central DI. What will you do now? What's the most common cause of central DI at this age group?
In a case of 2 to 5 years old child, one must look for the other pointers like any skin rash was present or.
So histiocytosis will be an important thing to look at. There is rash, seborrhea, bony defects. This is histiocytosis as a cause. 13-year-old boy with encephalitis on ventilator, polyuria suddenly is developed. There is hypernatremia. What is the diagnosis and what is the prognosis here?
The boy is developed after encephalitis. He is on ventilator and developed DI. So the prognosis is very poor in this setting. And
so what does it mean? There is a diffuse brain damage over a large area where the hypothalamic neurons are. So it's a bad prognosis scenario. It's a brain death DI. So now to management as far as hypernatremia is concerned, again, it depends upon the duration, and you want a gradual correction over 48 hours. Give maintenance fluid, give a free water deficit, which is 4 ml per kg, and the sodium deficit, and the ongoing loss has to be given. You don't want the fall to be more than 9 to 12 millimoles per liter in a day in acute, and chronic again 6 to 9. So something like hyponatremia, you want a gradual change. The protocol typically is like half normal saline is good enough. In most cases, 120% maintenance. But remember, whatever dose you give, there is a risk of rapid fall which will happen, and the risk of cerebral edema and seizures. So do sodium frequently. If there is cerebral edema or seizures, give immediately 3% saline to correct that. So again, we have got this calculator which provides you the dose as to what sort of dose and fluid rate you want to use in the acute management. So we have been over the last 2 hours and 45 minutes able to cover a lot of ground in terms of growth, obesity, thyroid, puberty, DSD, glucose, DKA, thyroid disorders, hypo and hypernatremia. So it's pretty much more than 2/3 of pediatric endocrinology we try to cover in this period. So all of this is available in the form of our app, which has got so many approach pathways, management pathways, which help you guide specific management, and you can download it through both Android and iOS stores. We also have the various courses for different groups, from the postgraduates to the fellows to the pediatricians, and we have got specific courses for the pediatricians as well as postgraduates in that regards. And of course, this mobile application will help you reach a diagnosis. So I'll thank all of you for patient hearing, for joining from all the places, and I'll thank specifically Alappan, Dhwani and Vibha for the wonderful discussion. We'll take a couple of questions which are there. So Dr. Palnir, am I saying FT4 and TSH should be done before food or ideally after 2 hours after thyroxine? So we should ideally be doing it before you take the tablet if you're doing FT4 to get a right result, because FT4 has a short half-life. Can 1/5 saline be used for correction of hypernatremia? Yes, but sometimes the gap becomes too much. So usually, if you remember that already normal saline is also hypoosmolar. So if it becomes too hypoosmolar, you will have a risk of rapid fall. So generally N/2 is pretty much good, Dr. Elizabeth, in that perspective. So I think we will close at this point of time. We also have subsequently we'll have a big announcement regarding the quiz, which will happen for everybody with regards to pediatric endocrinology probably next week sometime. So we'll be announcing the details of that soon on that regard. I think one more question before we go. And thank you,